Yes, sir. We are live and we are starting the session, sir. So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So, I would like to introduce the master of ceremony for today's session, Dr. Supriya Jaiswal, ma'am. Madam is the secretary of Patna Obstetric and Gynecological Society and is zone coordinator of Adolescent Health Committee, FOXY. I welcome you, ma'am, and would like to now welcome Dr. Niba Mohan, ma'am. Madam is the Joint Secretary of Patna Obstetric and Gynecological Society and Secretary Patna Manapa Society. We welcome you, ma'am. So I would like to now welcome Dr. Amita Sinha, ma'am. Madam is the Executive Member, Patna Obstetric and Gynecological Society and Chairperson, Family Welfare Committee of POGS. So we welcome you all, ma'am. I'm handing the session to you for further proceedings, ma'am. Over to you, Jaiswal, ma'am.
Okay, thank you, Dr. Stalin. So a very good evening to all of you. And I bring greetings from Team Patna OBGY Society to all of you, all the faculties. So today we have gathered here for a mixed bag webinar where we have incorporated different topics like difficult situations in cesarean section, the medical legal aspects, about the adolescent health and PCOS and infertility. So we have brilliant speakers here along with the chairpersons, esteemed chairpersons. And to start the program, may I request Mr. Stalin to have the lighting of the lamp. We invoke prayers to Lord Ganesha and start with the program.
Sure, ma'am.
Kurutvam kalyanam arogyam dhanasampada Shubham kurutvam kalyanam arogyam dhanasampada Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
धनसम्पदा.
Thank you. So, may I have the CV of Dr. Vinita Singh, please? So, to give the welcome address, I request our President, Patna OBGY Society, and a very dear sister to me, Dr. Vinita Singh, madam. She is Associate Professor in the Department of OBGYN NMCH Patna, consultant at Care Hospital IVF Center. She has already held many positions in FOXY, like FOXY ICOG Governing Council member, YTP Committee Chairperson FOXY, Joint Secretary, Clinical Secretary, Treasurer, and all the posts in the office of Patna OBGY Society. She had been the member of Safe Motherhood Committee, Quiz Committee, Practical Obstetrics, and many others of FOXY. Business Secretary of Patna Journal of Medicine, is Zone Coordinator, MTP Committee of FOXY. Madam has great organizational skill. She has been the organizing secretary of Nikon 2019, invited faculty at workshop at FIGO, Rio, participated in FIGO, Vancouver, organizing secretary of BoxCon, invited faculty in many national and international conferences, edited FOXY ICOG campus on PCOD, and she is the recipient of MG Mishra Award and George Mehani Award. With these words, may I request Vinita Ji to kindly give the welcome address.
Thank you, Dr. Supriya. Very good evening and a very warm greetings on behalf of Patna Obstetric and Gynecological Society in today's webinar, which is being organized in association with Delhi and Haryana Society. I'm really feeling extremely privileged and honored to welcome our very dear Dr. Alka Kriplani Madam, a very dynamic past president FOXY. I can say she is very talented, focused to her work, having diversity in the field of Gynec. Madam, I welcome you. As guest of honor, I welcome our own Dr. Alka Pandey, Vice President-elect 2023 FOXY. Whenever I think about silent worker, she is on top. A very humble, hard worker and gets involved totally whatever she does. I welcome you, Alka-di. I feel privileged to welcome again a very dynamic FOXYian, President Delhi Obstetric and Gynecological Society as guest of honor, Dr. Achla Batra. As guest speaker, I would like to welcome Dr. Vinayak Khetkar, Dr. Ajay Mane, Dr. Supriya Jaiswal, and Shivani Sasdeva Gaur for being generous enough to accept our invitation to speak in today's webinar. As chairperson, I welcome Dr. Kiran Mai, Dr. Vandana Punya, Dr. Sapna Jindal, who will be joining, Dr. Meena Samant, Dr. Monica Gupta, Dr. Renu Chugh, and Dr. Amita Sinha. I welcome all my seniors, past president, who has joined today's program, and I also welcome all my office bearer because without their effort, we can't have any program, a successful program, as I would like to welcome Dr. Nibha Mohan and all of his bearer. And lastly, I welcome all participants and pharma partner Shield Connect to sponsor today's program. So at last, I would like to welcome everyone who is present in this program. Thank you very much.
Thank you very much, madam. Now, may I have the CV of Dr. Alka Kriplani, madam? So, thank you, madam, for accepting to be the chief guest of today's program. We are really very thankful to you for this. Madam is very close to Patna Society. You've been visited so many times, and we had very good time with you, madam, at Patna. And we look forward for that you should come again and again. So, madam is President Foxy. She had been President Foxy in 2016, President GASI, President DGES, President AOGD, and Editor-Asian Journal of Obstetrics and Gynecological Practice on editorial board. She is the co-chairperson of FIGO Menstrual Disorder Committee 2016-18. She has got total of 47 awards. Madam has been conferred Padma Shri for Distinguished Service in Medicine by President of India. Dr. B.C. Roy National Award for Eminent Medical Teacher in 2007. She had been the Honorary FRCOG in London 2007, DMA Medical Teachers Award in 2014, IMA Mad Achievers Award, Rashtriya Gaurav Award. She's been awarded by many, CNBC Award, FIGO Award, Economic Times, by Economic Times, Most Inspiring Gynecologist of North India in 2018. She had 906 guest lectures, 72 orations, live workshop 156. She had got 405 publications, scientific publications, organized conferences, workshops, more than 130. She has got special interest in gynecological endoscopy and reproductive endocrinology, high-risk pregnancy. With these words, madam, I request you to say words of blessings to us.
Thank you so much for your kind introduction, Dr. Supriya ji. And I haven't met you many times, but your shining face, I'll never forget. And I will be visiting Patna because Patna is very close to my heart. You people are so loving. And before I go, I must appreciate Patna Society. There were times when Shanti ji and Manju Gita Mishra and now you people have taken over. Vinita Singh, I know for decades, she is doing such excellent work and she is so active for such a long time. So all other members who young girls I could see you people introduced, and my dear colleagues, Dr. Ajay Mane, Dr. Vinayak. So my dearest friend Achla, who is doing such a great work as AOGD president. So namaskar to everybody. And I wish Patna Society, this event, grand event, you people have become so academic. And Patna people organize, AICOG was so wonderfully organized. And you people are so humble. So one feels like going and meeting and having good time with you all. It's a pleasure. I can't ever, nobody can say no to Patna because as I said, you people are so friendly. And today's topics, difficult cesarean, I think it is a day of difficult things. Medical legal is very, very difficult for me. And I wish all the members enjoy these deliberations. And I wish all the best for all the people who are contesting elections. I tell you, these elections, that's just a reason for all of us to meet and know each other and enjoy our own, our own people. Another gynec, there is no close rishta than knowing another gynec. from another city doing such good work. So I wish all the contestants all the best. And I tell them, don't take things too hard. Some people win, some people lose, but it is your presence and your friendliness and the association you make with your own colleagues that is really very, very important. And thank you for inviting me. Thank you for your kind words. And I wish you grand success for this evening webinar.
Thank you, madam. Thank you very much for your wonderful words and encouraging words for all of us. Thank you very much, madam. And thank you for coming.
Thank you. Thank you, madam. Thank you very much.
May I have the CV of Dr. Alka Pandey, madam? So, thank you, Alka Di, for accepting to be the guest of honor today. Dr. Alka Pandey, madam, is Associate Professor, Department of OBGY, Patna Medical College Hospital. She is Vice President elect FOXI 2022, Member Governing Council ICOG, Chairperson Practical Obstetric Committee of FOXI, National Corresponding Auditor of JOGI, President Patna OBGY Society in 2012 to 14. She had been the Joint Organizing Secretary of 57th AICOG 2014 held at Patna, and then Organizing Chairperson 24th Boxcon 2014. With these words, Alka-di, I request you to kindly address the gathering.
Thank you, Supriya. It is a real pleasure to be a part of this webinar. Thank you, Vinita, and thank you, Supriya, for making me the guest of honor today. My regards to Dr. Alka Kriplani, madam. It is a real pleasure to be with you after a long time. My regards to Dr. Vinayak Khedkar, sir. I have seen him after so long time. I took charge from him. It's really a pleasure to see you, sir. And hello to Dr. Kiran Mai, Dr. Ajay Mane, Dr. Achila, and all other participants. And as we all know, cesarean section is a very commonly performed operations. Every day we are doing this. And we are facing difficult situations when we are in a soup. And we do get involved in medical legal problems. So this topic is very well selected, and good wishes, my wholehearted good wishes to Dr. Ajay Mane, Dr. Supriya Jaiswal, and any other contestant for the forthcoming elections. Thank you so much.
Kiran Mai.
Dr. Kiran Mai.
Dr. Kiran Mai. He is most probably uncontested. So
Ma'am, I need your blessings, all of yours, and all the support that I can get. Thank you.
Yes.
Thank you, madam. Thank you for such wonderful words. Now, moving ahead, can I have the CV of Dr. Achila Batra, madam? So, madam, thank you very much for agreeing to be the guest of honor of today's webinar. Madam is in the Department of OBGY, VMC, Safdarjung Hospital, New Delhi, President AOGD, President Narchi Delhi Chapter, Chairperson Urogynecology Committee AOGD in 1921, then Chairperson Rural Health Committee of AOGD, Honorary Secretary AOGD, ex-editor Narchi, Coordinator of Foxy Critical Care Conference 2016, UA Foxy North Zone 2018. She is a dedicated PG and UG teacher for 35 years. She has been conducting research projects for LSTM, ICMR, and Indo-US projects, author of workbooks of obstetrics, CBS Publishers. 2015, contributed several chapters in books and authored several original research papers in international and national journals. Reviewer in national journals, contributed to several MOHFW guidelines. With these words, madam, may I request you to kindly address the gathering.
Thank you, Supriya. Thank you for inviting me to your Patna webinar along with other societies. And it's become really nice, getting connected with each other through these webinars. Maybe when we meet each other in AICOG, we'll be able to recognize each other and not just pass by, And I always admire Patna Society, Dr. Vinita, Dr. Alka Pandey, who are doing such good work. And of course, my best wishes to all of you, Supriya, Ajay, Kiran Mai. And win or lose is, it doesn't matter. But the point that you have taken the initiative to, compete. That is more important, And today's topic is really relevant because now cesarean has become a pinnacle. Probably the government is going to come up with some laws that one cannot perform cesareans. And if you have difficulty in cesarean and have complication, that's going to be even worse. So I think everybody should be aware what are the complications one can have, how to deal with them, and the medico-legal aspect. I think the topic is really good. And it's going to be a great success. My best wishes for that. And it was good to connect with all of you, Dr. Alka, Dr. Ajay, Supriya, Vinita, Kiranmai, and thank you again for inviting me.
Thank you, madam. Thank you very much.
Thank you, madam. Thank you,
Thank you,
for
Archana
sparing
ma'am. Thank you so much.
Welcome back.
for sparing your time, ma'am, in spite of your busy routine these days. So with this, I come to an end of the inaugural session, and I hand over the session to Dr. Amita Sinha to conduct the first session. Dr. Amita Sinha, kindly unmute yourself. Amita Di, please conduct the first session.
Yes. A very good evening to all of you. Am I audible, Supriya?
Yes.
Okay. A very good evening to all of you. And after this inaugural session and address by chief guest and guest of honor, now we move on to the first session, and which is on difficult situations in cesarean section. And to conduct this session, we have two eminent chairpersons, Dr. Vinita Singh and Dr. Kiranmai Devineni. Dr. Vinita Singh, madam, have been introduced earlier for welcome address. But one thing I would like to say about Vinita madam, that she is very hardworking president, very lovable person, very academic and sincere. With these words, I welcome you, madam Vinita Di. Our next chairperson
Thank you, Amita.
is...
You have made my day with such a wonderful words.
Yeah, thank you, Vinita Di. Our next chairperson is Dr. Kiranmai Devineni. Madam is Professor OBGY at Government Medical College, Vanaparty, Kaloji University of Health Sciences, Hyderabad, Telangana. She is coordinator of Foxy Dhira Initiative, Stop Violence Against Women 21-22. And madam is going to be chairperson of this new committee of Foxy very soon. Really, this post is for you because we have been seeing you working for this committee. She is a scientific convener, AICOG 2021-2011, Hyderabad. And she has served as chairperson Adolescent Health Committee of Obstetric and Gynecologic Society of Hyderabad. She is postgraduate teacher and examiner. Recipient of Kamini Rao Yuva Foxy Orator in 2013. And MS Signature Award by Dr. Thomas Burgess Synergy for Global Innovations in Human Rights in 2021. She is also peer reviewer of Jogi for this year 2021 and co-authored 2 books and published research papers in peer-reviewed journal. So now I welcome you, Dr. Kiranmai, and I hand over the session to both of you.
Thank you so much, Vinita ma'am.
Yes, Dr. Kiranmai. So it's really a privilege to introduce Dr. Vinayak Khedkar, who is known by everyone. But for formal introduction, he was chairperson Practical Obstetrics Committee, Foxy, in year 2001 to 2014. AMOX website coordinator. He was Foxy committee member of Young Talent Promotion, Food, Drugs, HIV, Adolescent Health and Imaging Committee. Chairperson Infertility Committee, AMOX. Immediate past president of the Aurangabad OBGY Society. Organizing Secretary, AMOX 2009, Aurangabad. Organizing Secretary, Endo World 2011, peer reviewer of Foxy Journal, faculty speaker at Foxy FIGO International Conference, Mumbai 2011, maternal mortality hall concept with CD with help of Dr. Rajan Singh Pardesi and Dr. Gadappa in association with UNICEF and Government of India, and was faculty speaker for last 8 AICOG conferences and AMOX, MRCOG along with many societies. So we can see that how active member he is. Dr. Kiran Mai would like to introduce the topic.
Yeah. The topic is very, very important considering again, as Achla madam was telling, this is going to be the focus of the government in the next nearest future. So everyone has to fill up a form, I believe. Already it has started in few of the districts in our state, because our state has dubious distinction of very high cesarean section rates. So they are going to ask us to fill the form why you have done a cesarean section. So it becomes like more or less you are going to end up with having to do difficult cesarean sections in late labors and otherwise also. So, and I think most of the young generation or in peripheries have almost forgotten what we have learnt in medical college or in the tertiary institutes, where we are very proficient. You know, the situation makes you proficient in doing the patwardhans and difficult sections and all these things. So again, it is a relearning that has to happen, and it is our bread and butter. We have to be well versed with all the aspects of the difficult cesarean sections, and it was so nice to get to know you, Dr. Vinayak sir. It's almost the first time that I'm meeting you thanks to this virtual network, and very happy to see your CV, sir. Your lot of achievements. We are eager to listen to you. Thank you.
Thank you, Dr. Kiranmai and Dr. Vinita Madam. At the outset, I would like to say thanks to Patna Visual Society for organizing such a wonderful mixed bag webinar. And my younger brother, Dr. Ajay Mane, he is contesting for the Vice President election from West Zone for Foxy. So all the best to him, and he has done a tremendous work for this. And he's really, I'm sure he's going to come up with a record margin. That's for sure. And all the best, Dr. Kiranmai. As I said, your name is itself is perfect, and you're perfect for that post of No Violence Committee. Dr. Supriya, all the best to you and to all the contestants here. They are present, and in advance, congratulations. As Dr. Alka Pandey Madam said that she took over from me for the Practical Obstetric Committee, and she did a wonderful job. She really gave justice for that committee, and it's really wonderful committee. And I still remember the workshops during the Foxy workshops, and the Practical Obstetric Committee workshop used to be always a houseful workshop. People used to be sitting on the floor, you know. That was the kind of thing, and that trend continued with Alka Madam. And with her expertise, she gave a nice justice. So coming to my topic today, I'm going to talk, as everybody knows, about the difficult cesarean sections. As everybody is talking now, like the most commonest operation in OBGYN is a cesarean section. Rather, everybody is like no buts and do's and everything. They can perform the cesarean at any hour of day or night for that matter. And I still remember when I was in Wadia, during that, my first post, when it was my first emergency, I was in Purandare's unit, and that was my first emergency. I didn't know what is going on. And suddenly I was called, Vinayak, you come inside and assist me. So I went inside, and that cesarean was a Patwardhan's manure. And I was shocked. What is this like? That was my first cesarean section, which I was witnessing, and it was directly a Patwardhan's manure. So that created little concern for me. Is the cesarean section so difficult? But then later on, during that same emergency, we did 15 cesarean sections overnight, and I said, no, it's very peaceful. The operation is very easy, no problem. And next emergency, I did one. But then every time it is not the same thing. And suddenly you may get caught in some difficult situation, and then you will have a nightmare. So one should know exactly what things to be expected, especially with the prolonged labor or malpresentations, or with the previous LSCS, or with the uterus with fibroids. And then after anticipation, and if you are ready and you are well versed with some procedures, then I'm sure you can overcome these difficult situations also. With the increasing trend of the increased cesarean rate because of infertility and illegal abortions and so on, the late primiparas, there are multiple problems with the cesarean section also. So one should expect these things. Today's lecture, I have got some videos from Dr. Parag Biniwale and Dr. Srinivas Gadappa.
Sir, sorry to interrupt. Can you make the slides are not moving? Can you stop share and share again, sir?
Okay. What can you see on the slide right now?
It's on the first slide, sir. Difficult baby delivery at CS and not its slideshow mode also.
Okay. So I'll stop sharing and I'll restart then.
Sure, sir. Sure, sir.
Chitrakala has got very artistic voice, no? See how humbly she told you. If I would have been in her place, sir, it is not seen. Stop share. It would have been like that. Professional people are always professional people. Thank you very much, Chitrakala.
Thank you, sir.
Can you see now?
No, sir.
Okay. Sorry for the delay.
No problem, sir. May I help you, sir? Yeah. Yes, sir. Now the slides are seen.
It's not in the slideshow mode, sir. It is it's not.
Okay.
Sir, I will help you out, sir. Please
Yeah.
stop share, sir.
Yeah.
And while sharing again, please, don't select any icons from the dialog box.
Okay.
Yeah. Now, please click the share screen. Our dialog box will open. Please don't select anything. Just click on the share icon. That's it, sir.
So shall I open this window?
So don't select any window, sir. Just, yeah. Share screen, green color share, and then blue color share. That's it, sir.
Yeah, I'm sharing the screen.
Okay, sir. Yes, sir. Perfect, sir.
Yeah.
Thank you so much, sir.
Yeah, sorry for the delay. So this is an acknowledgement for Dr. Parag Biniwale and Dr. Srinivas Gadappa. Dr. Srinivas is the HOD of our gynec department, and he has done a wonderful job for OBGY. In fact, so many variety of cases and videos I'll be showing you. Is the slide moved now?
Yes, sir. Yes, sir.
Yeah. So one should be really familiar with the situation of the patient to avoid any mishap and any adverse neonatal outcome. You should be having adequate knowledge of the fetal eye. What is the presentation, whether it's an oblique eye or breech or transverse? If it's a vertex, what is the station? Is it a deeply engaged head or it's a deep transverse arrest? What is the degree of flexion? Is it a military attitude? And the position of occiput. See, maintaining flexion of the fetal head during delivery is utmost important. Say in every maneuver, you should try to maintain the flexion of the fetal head so as to present the minimal BPD during the extraction of the baby. The delivery of the shoulder and body should be with a gentle traction to avoid trauma to the baby. And the properly timed oropharyngeal suction, especially in the cases of meconium and whenever there is a lead deceleration, it is very important. Otherwise, there will be adverse neonatal outcomes. It has been seen that if the induction delivery interval is more than 8 minutes, then, and if the incision delivery interval is more than 3 minutes, then there will be adverse neonatal outcome. And mind it, this is for the spinal anesthesia. Whenever you are given a general anesthesia, this time interval is also less by 2 minutes. So what are the difficulties you can face during the cesarean section? It may be because of the abdominal or uterine access you may face. That is, most of the time you are taken a financial incision, and that is not an adequate incision if you are having a transverse lie, or if it's for the large baby. They can be abdominal or uterine scars. There can be lower segment placentas or fibroids. Cephalopelvic disproportion is very important, especially whenever there is a floating head or deeply engaged head. Abnormal positions, as I said, a transverse lie and bridge presentation, you should know exactly, and the deflex head. Other factors like multiple pregnancies, conjoined twins, macrosomia because of the gestational diabetes, prematurity, extremely prematurity is very dangerous because the head to body trunk ratio is disturbed. The head is bigger and the body is on smaller side. And if you try to extract with little pressure, there can be a liver hematoma also. And along with the fetal malformations like hydrocephalus. So let's come to the first problem, that is a floating head. And it is very common and it is associated with the polyhydramnias, gestational diabetes, or a large baby, or a CPD, and so on. Or you are taking for the elective cesarean section when the lower segment is not formed and there is a floating head. So the problem is inability to grip the fetal head. You won't be able to grip the fetal head properly, and there may be a change of position or presentation because of the floating head. So how to check? Like, one should know the placenta location in such cases. The placenta should not be anteriorly low down. You should anticipate a poorly formed vascular lower segments to modify the incision. Findings are to be confirmed on table. Fetus is to be manipulated in a longitudinal lie and steadied by a lateral support so that the floating head will come down to your incision line. So what are the options in such cases? If the membranes are ruptured and the liquor is drained, then you allow the head to descend and deliver after flexion. That is the commonest thing what we do. You should not open the membranes totally after taking a uterine incision. You should take a small neck and you should allow the liquor to be drained out. There should not be a gush, otherwise other structures may come in, but you should allow a small neck and a small drain of the liquor so that slowly the head will come down. You can assist by giving little frontal pressure on the bridge and thereby assisting the baby to descend down. In some cases, you may apply forceps or vacuum, or sometimes you may prefer to deliver as a bridge presentation. So this is one video. This is about how to deliver a floating head. After opening up, you will be taking a small neck after opening up with a lower segment, and you will allow the liquor to drain slowly. See here the surgeon, you can see there is a membrane. He first checked the head was floating. He has steadied the head, a small neck, and they are allowing the liquor to get drained. Once the liquor drain out, the head will present. Now the head is coming down and is presenting itself to the incision line. And still it won't be easy because the lower segment hasn't formed. So there is a difficulty in gripping the head. You can see that. But you should go in, you should firmly catch the head, take out the joints, catch the head. Assistant may give little fundal pressure in such cases. You should not leave your hand, flex the head. As you can see, he's flexing the head. And then with that fundal pressure, did you notice that there was a fundal pressure? And then you have delivered the baby. You may apply forceps also during the cesarean section. For that, sagittal sutures are to be placed transversely. There will be a slight fundal pressure to push head towards the incision and stabilize the fetal head. The concavity of the pelvic curve should be towards the fetal occiput. And the lower blade is applied first, followed by the anterior one. Flex the fetal head with traction. Crowning of the fetal head in abdominal incision, and the delivery is by controlled extension. Now, this video is by Dr. Nozer Sherier. Everybody knows Dr. Nozer, and thanks to him. So again, the membrane is incised. You can see the floating head, baby is moving. The joints is taken out. Is confirming that there is a concavity, nothing inside, and the posterior blade is inserted along with the concavity of the pelvis. So a check, no structure is caught in between. Now the anterior blade of the forceps is guiding slowly, and then again after confirming, give a little first push, first pull, and then you are confirming again, nothing is caught in between, and then maintaining the flexion, you are extracting the baby from the cesarean scar. Yeah, the baby is delivered now. So thanks to Dr. Nozer for this video. You can apply ventouse also during cesarean. If the soft cup is employed, it is partially collapsed and introduced through the incision. Rigid cups are turned sideways. It won't get collapsed. So you will have to manipulate. The edges of uterine incision are gently spread and the device is slipped in. The cup is applied directly to the fetal scalp as near the posterior fontanelle and sagittal suture as possible. A careful check of cup placement is followed. During traction, the pressure applied with the two fingers, the thumb against the dome of the cup and the index finger on the scalp in front of the cup, so as to establish a firm contact. So there won't be any leakage or spillage or from the head, and it will prevent the cup detachment. The traction has to be in a direction always perpendicular to the plane of the cup. So this is the basics of the ventouse application. Any oblique traction, even by 10 to 30 degrees, will reduce the effective traction force by 25 to 50%. Now, this is the video. This video is not getting played. I'll show you afterwards. Now, let's come to the deeply engaged head. Again, you should be doing a preoperative check and preparation. It's most of the time a second stage procedure. So you are given a fair trial to the patient. The cervix is dilated very nicely. It's fully dilated rather. There are signs of impending rupture. You should give a Trendelenburg position and uterine relaxant anesthesia. You need to catheterize the bladder so as to avoid any trauma to the bladder. Then there are options. You can take a lower incision in the lower segment of the uterus or higher incision on the uterus. If you are taking a lower incision, then the neck or a part of head can be at the presenting at the incision. So you can try for the vaginal disengagement, that is a push method. And another method is a delivery by bridge, that is a pull method. And you may apply a forceps also. If you are taking a higher incision or shoulders are presenting at the incision site, then you need to do a Patwardhan's maneuver. Now, this is a push method. So mind it, whenever the assistant you are telling to push it, you should tell him that he is not supposed to use only 2 fingers, because if he accidentally gives a extra pressure, excessive pressure on the posterior fontanelle, there can be a damage to the baby's brain. And that's the reason he should use at least minimum 3 to 4 fingers and try to cup it or hold the fingers like this in a combined manner, so that the force which he is applying will get distributed evenly over the scalp and there won't be any trauma to the fetal head. And then one should try to push little slowly but steadily. So this is a push method. And I know many of us were trying this only to begin with. You may try a pull technique. Now, pull technique is possible only when there is a sufficient liquor, and as soon as you are neck the uterus, don't allow the liquor to drain, just reach for the leg, and then once you get hold of one leg, give pressure on that and pull it towards the towards you, and catch hold of the second leg, hold both the legs together, and then you take out the baby in a regular bridge style manner. Now let's see the Patwardhan's method. Now this is very good method, and as I told you, it was the first method which I saw during my posting. And there are 2 methods. One is Patwardhan method, one is the modified Patwardhan method. It's nothing but if the back is anterior or back is posterior. Whenever back is anterior, you will have access to both the arms first. And whenever back is posterior, you will be having access easily to the hand and a leg, because the baby will fold itself on the abdomen. That's the reason you will have to deliver them accordingly. So whenever, now let's see what is the back anterior. Now, whenever there is a back anterior presentation, you should deliver an anterior shoulder first by hooking a finger in the elbow if required. Then you go posteriorly, rotate the posterior shoulder a little forward and hook a finger in the elbow and deliver similarly. Then follows the trunk, and while delivering and taking out the trunk, don't apply pressure on the ribs. You are supposed to stabilize the spine. You are supposed to keep your thumbs on the spine and gently grasp the fetal trunk and body. Again, whenever you are trying to take out the fetal body, you are supposed to catch hold of the pelvic girdle and not on the abdomen itself. So in that manner, the trunk, breech, and the lower limbs will be successfully delivered by the traction, and there should be a little bit of fundal pressure. Mind it, you are not supposed to keep the Pitocin drip running during all these maneuvers. We have got the habit of starting the Pitocin drip so as to prevent a PPH drip whenever we are doing the cesarean section. But whenever there is abnormal presentation, whenever you are going to try sub maneuver, don't start a Pitocin drip. What did I do? Have I come out like?
Chitrakala, please help him.
Sir, your screen is seen, sir. Please share the PPT alone, sir.
Can you see this Patwardhan's maneuver slide?
Yes, sir. Can you make? Yes, sir. Yes, sir.
Yeah.
Yes, sir.
So this is the fetal back anterior position. Now carefully see this video. It's a very nice video. Thanks to Dr. Urvashi. You're taking a neck on the lower segment, and you can see it's an higher level incision. because they are already given a trial, cervix is fully dilated. You can see the back is anteriorly. Now this is most important. Go for the anterior shoulder, hook it from the shoulder joint and from the elbow by flexing it. So one hand is delivered. It stopped suddenly. I'll show more method. Can you see this video?
Yes, sir.
Yeah. This is by Dr. Gadappa. You can see the back at the incision. See, one anterior shoulder is delivered by giving the pressure in the elbow. Now going for the posterior hand, rotated anteriorly and taking out with the posterior shoulder. Can you see this? Yeah. Now you are trying to deliver the back and the trunk. The baby has been delivered now. Maybe because of the videos it's coming out. Now let's go to the Can you see the slide? Fetal back posterior?
Yes, sir. Yes, sir.
Yes,
Yeah.
yes, sir. Yes.
Now the back is posteriorly and you can see already one hand and one leg is been getting delivered. That is the presentation. So you have to deliver the same side the hand, same side leg and the opposite leg and then opposite shoulder and the baby will be delivered. So what are the chances of complications during these maneuvers, especially the Patwardhan maneuver? Then there was a study, the study group and the control group of 50 patient each. There was a uterine artery injury in the control group, bladder injury in the control group, excessive bleeding and trauma with atonic PPH, more frequency with the control group. Blood transfusion was needed in more number of patients with the control group. Need for hysterectomy were in 2 patients in the control group. And the fracture humerus was in the study group, which was not there obviously in the control group. It is obviously because of the hasty or in panic situation, if you try to take out the shoulder very rapidly, then there will be a fracture. So there can be other malpresentations also during cesarean section like transverse lie. You need to try an external version also. Dr. Adi Dasturi used to try out in the ward, but then many times what used to happen, at night he used to align the baby and in the morning when he used to come for the round, it again used to go back to the malpresentation and we used to land up with the Caesar only. Otherwise, external version is an option if the membranes are intact. The transverse lie is to be converted to the longitudinal one and the Kefalic option is an option, though conversion to breech by traction feet are preferred one during the cesarean section. So knowledge of the position of the fetal head is very important before taking this incision on the uterus. A liberal J-shaped incision in lower uterine segment should be necessary if the baby is term with or without premature rupture of the membranes. And the delivery of breech usually is being carried out or vertex if it's an oblique line. If there is a breech, everybody knows how to conduct a breech delivery. It's the same thing. Only thing again, not to start a pitocin drip so as to avoid the hair getting caught, and similar manner, and you are supposed to deliver a breech. Extreme precaution is to be taken whenever there is a premature breech, because they are more prone to the injury as the lower segment is thick walled and gets retracted easily. You need to avoid trapping of the aftercoming hair by manures like Morris's smelly wet manure or Burns Marshall manure, or you may apply Piper's forceps also in such cases. Why it is important to give more attention during such difficult situations so as to avoid neonatal complications? Because during hasty or in panic situation, you may take a deep or uncontrolled uterine incision, and that may cause incisions on the fetal parts, or there can be inappropriate or inadequate uterine incision, thereby trapping of the fetal parts, and the delay or difficulty in fetal extraction itself can cause trauma to the baby. So incidence of injury is 0.4% during cesarean section for the vertex presentations, and it is 0.5 to 1.5% of cesarean section during breech delivery, but it's the same for vaginal delivery also, vaginal breech delivery. It's the same complication rate. The types of injury are obviously, if it's a presenting part is head and you are taken an incision on the head, little deep one, then you may lacerate the skull. There can be dislocation of nasal cartilage. There can be fracture clavicle, unilateral brachial plexus if you are pulling unnecessarily in inadvertent manner. There can be spinal cord injury, the liver hematoma if there is excessive pressure on the abdomen. The fracture tibia and radius and the fracture femur is been known, and there can be vascular injuries like subclavian or the neck vessels due to spasm or lacerations. So remember, friends, you need to always remember the preoperative assessment is to be taken during all the difficult situations. You need to plan. The preoperative planning procedure is very much needed, especially if it's a transverse lie, oblique lie, or deep transverse arrest. You need to keep standby ready if you are doing a push method. You need to align the baby if you are planning to deliver either by breech or by vertex extraction. You need to give an appropriate anesthesia, the muscle relaxant anesthesia for such maneuvers. No pitocin drip if you want to try Patwardhans or any such maneuvers. If you are not confident, or it's better to call a senior obstetricians and expert assistance during all these procedures. Presence of neonatal, this is very much important, as and Dr. Ajay Mane will definitely tell you about the medical legal consequences, that if you are not expecting any problem, it's an elective cesarean section, you haven't called neonatalist for that matter, it's a full term baby, good baby, there is no complication, no risk factor, then still the neonatalist should be there with the starting of the cesarean section. Before taking an uterine incision, neonatalist should be there to avoid any mishap and any legal complications afterwards. So once Winston Churchill has said, if you are going through hell, keep going. Because if you get stunned, if you get panic, if you get frozen, there'll be definitely adverse outcome. So coping with difficult situations, don't freeze. This is my photo from KM Hospital at time of our get together, and remembering the first Patwardhan's manure, which I had assisted without knowing what is Patwardhan's manure. Thanks a lot for listening to me patiently.
Dr. Kiran Mai?
Yes, ma'am. The videos and the whole structure of the presentation is extremely, extremely useful, and very, very beautiful videos, and your slides also. So, though we think we know, but there is a lot to learn every time we listen to our senior colleagues and seniors in our field of specialty. Thank you so much, sir, and I also thank Dr. Ajay Mane, sir, Alka Kriplani ma'am for, I could see madam and listen to her words of blessing. Then our guests of honor, Dr. Alka madam and then Dr. Achla madam. So all the host societies, Patna, Delhi and Haryana, dear Dr. Supriya and Dr. Ajay Mane sir and Dr. Vinita Singh madam for this invitation, for this kind invitation. I've been really enjoying this and very happy to join here. Vinita ma'am?
Yes, Vinita. Vinita di?
Yes, Dr. Vinayak, really it was a wonderful, mesmerizing talk. And we always, face so many troubles in delivering baby during cesarean sections, especially sometimes even in technique. If there is any in difficult situations during cesarean sections. And my all best wishes to all participants who is contesting. Dr. Kiran Mai, you are winning, I know. So you have to go ahead with lots of work and you are doing so much of work involved. And Supriya Jaiswal and Dr. Ajay Mane. So yes, so Dr. Ajay Mane is going to win with a thumping vote. So all the best wishes and Supriya Jaiswal, my all blessings to you. So
Thank you, madam. Thank you very much.
Yeah. Thank you for this wonderful session. I especially thank Dr. Vinayak with Khedikar sir for your brilliant presentation. You are true obstetrician because despite few interruptions, you were so cool and it went very well. We saw all the videos. All the videos were very informative. So, and what to say about our two chairpersons, both were brilliant. Their input was very great. So I thank all of you for this wonderful session. And my best wishes to Ajay sir, Kiran Mai and Supriya for all the forthcoming elections. Thank you so much. And to conduct the next session, I request Dr. Nibha Mohan, Joint Secretary, Patna OBGY Society, to take over. Dr. Nibha.
Basically, all the chairpersons and the speaker, they are teachers, no? So they need to be teaching coolly, whatever may be the hurdles. They will be teaching forever.
Was very good.
All our professor.
It seems that, you are tired.
Ajay Mane sir, you had said, no, the videos were very nice. So, Vinayak sir, your videos were perfect, very nice, very clear.
Thank you.
Basically, Dr. Vinayak is perfect. He is my elder brother, basically.
Thank you, Ajay.
Thank you.
Again, my best wishes to all the participants, all the contestants. Thank you.
Nibhadi.
Okay, thank you, Amita. And at the outset, thanks our President and the Secretary for giving the opportunity. At the outset, my warm regards to all the seniors and dear friends. We just finished the first session and moving to the second session. This is regarding medico-legal issues in labor and cesarean section. So we just listen to all the difficult situations we all obstetricians are facing. So naturally, we are exposed to so many medico-legal issues. To listen this important topic, we have with us none other than Dr. Ajay Mane. Can I have his CV, please? Okay. And Dr. Ajay Mane is chairperson at present of website committee and going to win for Vice President West Zone Foxy. So all the best, sir. To conduct this session, we have two eminent chairpersons, Dr. Vandana Punya. She is a professor and fellow IMA-AMS, FIAMS, State Chairperson, Women Doctors Wing, IMA Haryana, past member of IMA National Standing Committee on Safe Motherhood, past Chairperson WDW MPH Bhiwani, and she's President Foxy Bhiwani, past State Vice Chairperson, I think it's something Women's Doctor Wing, and MPH IMA Haryana. So welcome, Dr. Vandana.
Thank you, ma'am. Thank you.
And to join her as to chair the session is Dr. Sapna Jindal. Dr. Sapna is Secretary of Foxy Palwal, and she is consultant at Anmol Hospital, Palwal. So over to both the chairpersons to conduct the session. So may I request Dr. Vandana to invite and introduce Dr. Ajay Manisan.
Thank you. First of all, at the outset, I would like to thank the Patna Society, especially Dr. Supriya and Dr. Vinita, for making me part of this mixed bag webinar. It was an honor listening to Dr. Vinayak, and I'm sure Dr. Ajay is going to enlighten us with a lot of other things that we have to undergo today, because I think all of us as obstetricians are facing problems with cesarean sections and labor. So it's my honor to introduce Dr. Ajay Mane. He's a member of the National Inspection and Monitoring Committee, PCPNDT Wing, Government of India, a medical legal consultant since the past 18 years, giving advice free of cost. He's the chairperson, official AMOGS website, the chairperson in the Sexual Medicine Committee. He's the chairperson of the Adolescent Health Education Committee, Joint Secretary, Maharashtra State Association of Obstetrics and Gynae. He's the past president of Aurangabad OBG Society. Is a national trainer of Foxy Adolescent.
Vandana, madam, it's enough. Thank you, madam. Thank you very much.
It's really wonderful, and it's my privilege to introduce such a wonderful person. And I'm looking forward to listening to you, because I think this is one topic which all of us are really facing. And again, I would love to thank Society of Patna for such a wonderful talk and introducing this particular topic. And I think without any delay, I would request Dr. Ajay to carry on with the session.
Yes, ma'am. Thank you, madam. Thank you, Vandana, madam.
Thank you, sir.
Now we'll start. To start with, I convey my gratitude to Vinita, madam, and Supriya, ma'am.
Yes, sir. Yes, sir. I was calling Sapna Jindal, ma'am. Yes.
Okay. Now today's topic is medical legal issue in LSS and labor.
Yes.
I'll make it a full screen. Is it seen completely? Hello?
Yes, sir. Yes, sir. Yes, sir.
Yeah. Yes. Thank you. Thank you very much. And my gratitude to Alka Krupalani madam, Dr. Alka Pandey madam, and Dr. Achila Batra madam, who in spite of very busy schedule, taken out time and blessed us today. And I'm very much thankful to organizers, Dr. Vinita Singh madam and Dr. Supriya Jaiswal madam, who is now my family members, Vinita ji and Supriya ji. Thank you very much. And my co-speakers, Dr. Vinayak Kedkar, who is my brother, and Dr. Shivani Sisdev, a very good friend of all of us from Delhi, and Dr. Supriya Jaiswal ji. And all chairperson, Dr. Vandana Punia ma'am, Dr. Kiranmai Devinani ma'am, Dr. Sapna Jindal ma'am, Dr. Meena Samant ma'am, and Dr. Monika Gupta madam, Dr. Amita Sinha ma'am, and Dr. Renu Chu ma'am. Thank you very much. And Dr. Niba Mohan and Dr. Amita Sinha as a great MOCs for taking the program smoothly, and Patna Obstetrician Society, Delhi and Haryana Obstetrician Societies. Thank you very much. To start with, I have got some situations and the answers. Patients came with the pregnancy of 17 weeks for first time, and her age is 17 years. What next? 17 weeks pregnancy is no problem, but age is 17 years is a problem. Why? Because if it is less than 18 years, completed 18 years, not started 18 years, 17 completed, 18 started, is not an adult by law. What is the definition of adult? 18 years completed is a adult in India. So less than 18 years pregnant, whether married or unmarried, carries no importance. Less than 18 years completed, pregnant comes under POXO Act. It is a protection of child from sexual offenses. Many of the consultants I have heard uttering it as a POSCO, but no, it is a POXO Act. Okay, and it is applicable to all of us. We are bound to inform the police whenever we come to know that a girl is pregnant or who is less than 18 years. If we do not inform the police, we are liable for a 6 months imprisonment. They are very dangerous situation at that time. So inform police in a written format and keep a receipt with you from the police, and then go for the further procedure. You don't have to wait for the police. If she has come for the MTP or if she has come for the ANC regular checkup, just to inform the police. Though patient agrees or though patient do not agree, you need to inform the police. It is for your safety. Okay. So follow the protocols, and documentation means you have to keep a situation. Next situation, do we need a consent for labor? Obviously, yes. Can a patient give consent who is in active stage of labor and pains? No, because in consent it is said that sound condition of body and mind is required, and a patient who is in pain and agony or under influence of any drug or under influence of any anesthetics drug is not a sound condition of mind. Okay, and if she is under pain, then it is not also not sound condition of body. So the consent given at that moment is not a valid consent. So what to do? You can take a consent of a near relative who is waiting outside the labor room or the operation theater, who is waiting there. That is the one remedy. Second remedy is that at the last ANC visit, you should take the advance consent for the labor. Okay, that is second remedy. And third remedy, take an advance consent from that patient, and in that consent she said that if something goes wrong or I need to go for another situation or another procedure, and for that situation doctor is free to perform the operation or procedure on me, I am here with, I am giving consent, or she should appoint one person, maybe father, mother, husband, or very near father-in-law, mother-in-law, and who can give consent on behalf of her in that situation. That is the third remedy. There are three remedies. First, during last ANC checkup, have a signature. Second, have an advance signature, which is given in Fox's website. And third, appoint a person by the patient to give on behalf of the patient. That is section 88 of Indian Penal Code, that gives a relative, very near relative, or a relative appointed by the patient in good faith, that the patient's relative can give consent on behalf of the patient. That is remedy. There are so many remedies, but we don't know, or rather we don't pursue or follow. Okay, can a relative give consent of the patient? That I answered. Uniform consent of Foxy is being given in the www. You got this uniform consent book, complete book of 30 consents. Uniform consent, there are two parts. One is information part, second is undertaking. So please download it and get a printout of it, and you can use it in the your hospital's name. Put your hospital's name on the top, and you can use that complete consent. So for normal labor, page 95 to 104 of the book, they have given every detail. Part 1 is information about the procedures, name of the procedure, then meaning of the procedure, then emergency cesarean section, then purpose, description, benefits, effect of the procedure, alternative of the procedure, consequences of refusal of the procedure. So all is, everything is mentioned in that. Okay. Since it is a natural process, then outline, then unexpected events, then morbidity of natural normal delivery. Then part 2 is undertaking, where all we have to fill in the blanks: name, age of the patient, address, thing, and then in my relation, who is doing. And this is the very important part: sign of patient, sign of doctor, and this is one from doctor side, one witness from patient side. Why? Because it is an agreement between a patient and a doctor. So we need to have a sign of patient and sign of doctor. If the doctor do not sign the consent form, it is incomplete consent form, not accepted by the court if something goes wrong. So need to have there they have given information about the check curetas, labor anesthesia, epidural anesthesia, everything. So that finishes the normal labor consent in Foxy. Now the situations. Next situation is IUFD, G4P3L0, type 2 diabetes mellitus, very bad patient. Presents at 39 weeks with IUFD on admission. Okay, maybe registered or unregistered. It seems that she is registered, depending upon the lower situations. G4P3L0, okay, type 2 diabetes mellitus, having all consequences. IUFD on admission. Okay, and we have done everything. And what is the take-home message from this case? Did not come for checkup as advised. She did not turn on the stipulated time. So documented. Patient do not come. Likewise. Okay. Next thing, did not get blood sugars done regularly or early. Documents. Documented. Then did not take insulin as advised. So patient is not following the instruction by the doctor. Documented. Why to document? Because these are helping hands of you. because something goes wrong. She is a known case of complications. So this time she is with IUFD, and these documented things will help you that you are not negligent. You have followed the protocols, you have given all instructions, you have given all proper treatment, but the failure is on the patient's part, and that becomes a contributory negligence. What is contributory negligence? It is negligence on the part of patient, not on the part of doctors. Means we. It is a negligence on the part of the patient, and this is helpful to doctors. When the contributory negligence is there, a doctor is not held liable for the negligence, because the negligence is done by the patient. So we have to have a documented evidences for that. At the same time, whenever you give instruction to the patient को ट्रीटमेंट नहीं, शुगर नहीं कर रहा है, आप उसको राइट डाउन कीजिए एक बार से, एंड वॉट एवर यू राइट ऑन द पेपर इज कंसिडर्ड एज करेक्ट बाय द कोर्ट, बिकॉज यू आर एक्सपर्ट. आपकी दुश्मनी तो नहीं उसके साथ में, आप झूठ मूठ तो नहीं लिखेंगे, ये कंसिडर किया हुआ है कोर्ट ने. सो इफ यू राइट एनीथिंग, इट इज कंसिडर्ड एज करेक्ट. Next situation, again IUFD, document patient's non-compliance in the outpatient record. अभी तो कुछ लोग तो इंडोर पेपर नहीं है उसको दे रहे, पर उसमें भी आपने लिखना है और एक कॉपी आपके पास रखनी है. Because something goes wrong and patient won't produce the record. वो बोलेंगे हमारे पास तो है ही नहीं, गुम हो गया, लाए नहीं, कहाँ गया मालूम नहीं, बिकॉज उनको ऐसे पढ़ाया जाता है पेशेंट को. तो अपने पास उसकी कॉपी होनी चाहिए ओपीडी पेशेंट की. ओके, एंड इंडोर की तो ऑब्वियसली रहती है अपने पास. So, well, indoor को. Primary with severe PIH presents at 39 weeks with the IUFD on admission. Same thing, but ये इसमें hypertension है, उसमें diabetes था, बाकी सब थी. Did not come for checkup as advised. Document did not get blood pressure check. Did not take treatment. Did not maintain fetal movement count. उसको बोला है 2 दिन से बच्चा सो ही रहा है, मुझे लगा आराम कर रहा होगा, तो मैं आज आई हूँ. Okay, so this is the situation, and today I'm very happy to tell you that before 15 days back I was delivering same lecture, how to document, rather basically it was a different lecture, how to document and what to document in such situations. And there was one secretary of our society, and today she rang me, sir, thank you very much for your lecture. Well, so thank you. No, it is a special thank you to you, as yesterday only she had a incidence of having one patient at 11 p.m. with IUD. She admitted the patient. On admission, the patient was having 6 centimeter dilatation, but I'm so sorry. She was having a sonography report of IUD done outside the hospital, and she got admitted the patient, and within half an hour or 1 hour, patient delivered the dead baby, and she has done all the documentation properly and correctly, as it was very fresh knowledge for her. And today 2-3 what the journalist and all the people, somebody called, you are doing illegal MTPs of very 32 weeks pregnancy, likewise, but she said no. You come to my hospital, she rang me, and sir, what is the principle? 1, 2, 3, 4, 5, 6, 7. Okay, everything is done. So not to worry about. She has kept the sonography report with her. She has kept the notes on admission. That will help, because on admission, the baby's fetal count, fetal heart count was 0. And she has got a report of IUD, a sonography report done outside. So no forgery is done. So everything is in favor of this doctor. She has just given services to the patient. Nothing was done by the doctor. So IUD was outside the hospital. So she is not responsible. But see how people, they are taking disadvantage of such situations. Many of the journalists came knowingly, unknowingly, or directly, indirectly, asking for something. Madam, you have done some wrong thing. हम ये छापेंगे, वो छापेंगे, फिर हम आना है कि नहीं आना है. Likewise. So this is a fixed situation. तो आपने अगर ये follow किया है protocol, so don't worry. Nobody can touch you. Nobody can blame you. Okay, that is the incidence. Next situation: patient is in PPH, and you have not done the blood grouping prior, as patient was your registered patient. अगर registered patient है, आपने उसका blood grouping first visit में ही आपको blood group करना है, उसका नहीं किया है, तो is it negligence? Yes, it is a negligence. अगर PPH में गया है, आपने manage किया उसको well, patient is saved, so आपका negligence उसमें नहीं दिखता है at that moment for PPH only. But आपने उसका blood group नहीं किया है, ये आपका negligence है. If patient goes in the court of law, rather in Consumer Protection Act, you are liable for the सिविल नेग्लिजेंस एंड यू नीड टू गिव द कॉम्पेंसेशन. अब कॉम्पेंसेशन कितना क्या है वो जैसा आप डिसाइड करेंगे, बट यू नीड टू गिव द कॉम्पेंसेशन. इसमें अगर पेशेंट की डेथ हो जाती है तो बिकम्स क्रिमिनल, है ना. क्रिमिनल नेग्लिजेंस में आपको कॉम्पेंसेशन भी देना पड़ेगा और आपको 2 years इम्प्रिजनमेंट भी हो सकती है. तो देयर आर 2 टाइप्स ऑफ नेग्लिजेंस, सिविल एंड क्रिमिनल. सिविल में आपको सिर्फ पैसे देने पड़ेंगे, क्रिमिनल में आपको सजा भी हो सकती है, नहीं भी हो सकती है. ओके. Do we need a consent for CS? Again, same question, for just replace the word CS in place of labor. Then can a patient give consent who is in active stage? Again, no. Can a relative give consent? Again, yes. Okay. And uniform consent book में दिया हुआ है, page number 104 of book. Consent for the cesarean section. Name of the procedure, meaning of the procedure, purpose of the procedure, then description of the procedure, everything. Then benefits of the procedure. Then alternatives, consequences of refusal of the procedure. नहीं, बहुत सारी बार आगे है procedure, अभी मैं बताऊंगा. Outline of the substantial risk, anesthesia की risk अलग से और anesthesia. It is very, very much important to have a separate consent for anesthesia. Every time you do something procedure with the patient and having an anesthesiologist with you, have a separate consent for anesthesia. There are 3 things basically for which you need a consent. One is your operative procedure, whatever, maybe DNC, DNE, Caesar, normal labor, episiotomy, whatnot, but you need to have a consent. Secondly, second consent for anesthesia. So separate notes for procedure, separate notes for anesthesia, and third consent is very much mandatory if you transfuse the blood with the blood to the patient. Okay, blood transfusion is a separate procedure and have a third separate procedure for blood transfusion. हर बॉटल का ट्रांसफ्यूजन का आपका कंसेंट लेने की जरूरत नहीं है. शुरू में एक बार ले लीजिए कि हम इनको ट्रांसफ्यूजन दे रहे, मे बी फिर 2, 3, 4 बॉटल जितने लगेंगे आप दे सकते हो. हर बार कंसेंट लेने की जरूरत नहीं है. But to start with, before starting the blood transfusion, you must have a consent for the blood transfusion. Okay. इमरजेंसी सीजरेन सेक्शन ये भी दिया हुआ है उसमें. क्या उसका रीजन क्या हो सकता है, उसके पर्पस क्या हो सकते हैं, उसके ये क्या इंडिकेशंस क्या हो सकते हैं, जो जनरल इंडिकेशन दिए हुए. अब अंडरटेकिंग है, साइन ऑफ द पेशेंट, डॉक्टर विटनेस टू, एडिशनल टिप. व्हाट इज एडिशनल टिप इसमें सीजरेन सेक्शन में? कि अगर आप उसमें एनेस्थेसिया में बोल आप ले सकते हो, इमरजेंसी है, पेशेंट नहीं दे पा रहा है तो उसके रिलेटिव का आप ले सकते हो. ठीक है. क्वेश्चन next, how many years do we need to maintain records? This is very much important in view of today's era. लेबर का रिकॉर्ड आपको 21 years रखना है. क्यों? अब लॉजिक ये है इसके पीछे, जो भी बच्चा अभी पैदा होने वाला है या बच्ची पैदा होने वाली है वो बड़ी होगी, 18 साल की बाद में वो शील और ही विल गेट द एज ऑफ मैच्योरिटी और एडल्टहुड. एंड उसके बाद में वो सोचेगी कि ये डॉक्टर ने मेरे साथ बहुत कुछ तो भी बेकार किया है और इसकी वजह से ये बर्थ इंजरी हुई है मुझे, तो मैं इसको कोर्ट में खींचूंगी, और उसके लिए उसको टाइम दिया गया है. सो वी नीड टू हैव अ रिकॉर्ड ऑफ 21 years. ये बहुत जाती है. इट इज वेरी बैड पार्ट ऑन द डॉक्टर्स व्यू, बट वी कैन नॉट डू. वी नीड टू मेंटेन द record for 21 years. Second, any procedure, whatever, 7 years. MTP 5 साल के लिए है. PCPNDT 2 years. CPA 2 years. And insurance 7 years. But in CPA, now in 2019, they have got some amendments in CPA. In that amendment, they said that if the judge feel, वहां 2 साल तक ही केस कर सकते हैं CPA का, कंज्यूमर प्रोटेक्शन एक्ट का. बट if the judge feel कि it is the gross negligence and the cases to be admitted maybe after 3 or 4 years, he or she, the judge, may get admitted and we need to produce the document. But हम तो 2 साल के बाद में उसको नमस्ते कर चुके होते. इसलिए मेरा एक आपको एडवाइस है कि पूरा रिकॉर्ड आप 5 साल तक मेंटेन कीजिएगा, है ना. प्लस माइनस कुछ हो गया तो 5 साल के अंदर हो जाएगा, 5 साल के बाद में होने के चांसेस बहुत कम रहते हैं. नेक्स्ट सिचुएशन, अनरजिस्टर्ड पेशेंट केम इन अर्ली लेबर. अर्ली लेबर जस्ट पेन स्टार्ट हुआ है, मे बी 1 सेंटीमीटर, नॉट रेडी फॉर एनी इन्वेस्टिगेशन. हम कुछ करेंगे, हमारे पास पैसे नहीं है. ओके. एंड आस्क फॉर एडमिशन एंड डिलीवरी. कैन वी डिनाई? यस. Why? Because she is an unregistered patient, so there is no moral duty of you to get admitted, the patient admitted. And early labor में है तो कर सकते हैं. अगर लेट लेबर में है, एकदम सेकंड स्टेज का स्टार्टिंग हो रहा है उसका, उस वक्त यू कैन नॉट डिनाई। और लाइफ थ्रेटनिंग कंडीशन है, पीपीएच में है पेशेंट, बहुत ज्यादा ब्लीडिंग हो चुका है, उसका शॉक में है, घर में डिलीवरी हो गई, रिक्शा में डिलीवरी हो गई, आपके वहां आने तक वो पेशेंट इज इन शॉक, तो आप उसको डिनाई नहीं कर सकते। यू हैव टू टेक इनसाइड एंड रादर ट्रीट द पेशेंट। तो इन्वेस्टिगेट करने से पहले उसको ट्रीटमेंट शुरू कर देना चाहिए उसका, ठीक है ना। सो लाइफ थ्रेटनिंग कंडीशन यू कैन नॉट डिनाई द पेशेंट, बट हियर इट इज अनरजिस्टर्ड पेशेंट, शी इज इन अर्ली लेबर, सो यू कैन वेरी वेल डिनाई, इट इज योर राइट, आप पेशेंट को डिनाई कर सकते हैं। बट सेंड विथ प्रॉपर डॉक्यूमेंटेशन, उसका जो भी फाइंडिंग लिखो, आप उसमें कंसेंट ले लो कि हम दूसरे दवाखाने में भेज रहे हैं, हम यहाँ इन्वेस्टिगेशन करने को तैयार नहीं, तो हमने डॉक्टर साहब ने हमको मना किया है, तो वी आर गोइंग फॉर द गवर्नमेंट हॉस्पिटल और मे बी अनदर इंस्टीट्यूशन, रेफरल लेटर देना है उसके साथ में, एंड ये आपको एक कॉपी आपके पास रख के उनको जाने देना। नेक्स्ट सिचुएशन, रजिस्टर्ड पेशेंट है, अब ये अनरजिस्टर्ड नहीं है, रजिस्टर्ड है, तो मोरल ड्यूटी बन गई आपको उसको लेना है। पेशेंट विथ रूटीन फॉलो came at full term in labor insisting for normal delivery only, नहीं आप नॉर्मली करो, हम सीजर नहीं करना चाहते, एंड नॉट रेडी फॉर CS इफ नीडेड एज द फीटल हार्ट रेट इज फ्लक्चुएटिंग, मे बी 120 से कम है, 160 से ज्यादा है, फ्लक्चुएटिंग है, तो आपने क्या करना है उस वक्त में, उसका रिकॉर्ड प्रॉपर फाइंडिंग, उसका जो भी है, डायलिटेशन कितना है, डिस्टेंट कितना है, क्या क्या कंडीशन पूरा रख दीजिए, उसमें पार्टोग्राम मेंटेन कीजिए। पार्टोग्राम इज वेरी इंपॉर्टेंट। व्हाई पार्टोग्राम इज इंपॉर्टेंट? बिकॉज इन वन लुक यू कैन से कॉन्ट्रैक्शंस कितने थे पर 10 मिनट्स, कितने थे पर 30 मिनट्स, कितने थे, उसका नेचर कैसा था, उसका हेड का डिसेंट कितना था, डायलिटेशन कितना था, लाइकर का कंडीशन कैसी थी, उसका बीपी कितना था, ये पूरा एक वन लुक में मिल जाता है। एंड पार्टोग्राम इज अ लीगल डॉक्यूमेंट, so please maintain partogram. It is not necessary to maintain only in institution or in medical colleges. You can maintain in your private hospital also, because it is a very good diagnostic tool. You can say, जैसा अभी तो मैडम ने बोला सीजर के लिए आपको फॉर्म भरना पड़ेगा, और आप सीजर क्यों कर रहे हो, क्यों कर रहे हो, कि इसका जवाब पार्टोग्राम में है। कि ये सिचुएशन थी, ये लाइन के इधर जा रहा था पेशेंट, राइट साइड की लेफ्ट लाइन के लेफ्ट में होना चाहिए, एक्शन लाइन के राइट में गया, तो हम उनको सीजर के लिए पोस्ट कर दिए, खत्म हो गई बात, तो आपका जस्टिफाइड हो। सो पार्टोग्राम इज वेरी इंपॉर्टेंट टूल। फिटल रिकॉर्ड रखिए, उसमें सीटीजी दे दीजिए उसका, नेगेटिव कंसेंट। अब व्हाट इज नेगेटिव कंसेंट? पेशेंट सीजर के लिए तैयार ही नहीं, तो उसको नहीं तैयार किया, मेरे को लिख के दो मैं तैयार नहीं हूँ, दैट इज नेगेटिव कंसेंट। और डॉक्टर साहब ने मुझे सब समझाया है, but I am not ready for the cesarean section. Whatever the consequences will take place, I will be wholesale responsible for that. That is negative consent. ठीक। और पेशेंट अगर नहीं रुकना चाहता, आपके पास कहीं बाहर जाना चाहता है दूसरी जगह, तो आप भेजिए, आप जबरदस्ती उसको रख नहीं सकते। ओके। रेफर विथ ऑल प्रोटोकॉल्स। व्हाट प्रोटोकॉल्स? डॉक्यूमेंटेशन एक कॉपी आपके पास, रेफरल लेटर एंड सेड अप इन अ proper ambulance, not in a car or rickshaw. Situation: patient not progressing well in labor and not ready for CS, routine position है, and not ready to shift also. अब जाऊंगी भी नहीं, सीजर भी नहीं करूंगी, यहीं करो जो करना है, तब क्या करेंगे? तभी वही है सेम। अगेन एक्सप्लेन consequences, keep all records, denial of shifting and negative consent. अब इसमें एक सिचुएशन ऐसी है, पिछले बार किसी ने पूछ लिया कि नेगेटिव कंसेंट देने को पेशेंट तैयार नहीं, सीजर भी नहीं करना चाहती, दूसरी जगह जाना भी नहीं चाहती, और मैं नेगेटिव कंसेंट भी नहीं दूंगी, तब क्या करें? तो तब आपने ऐसे करना है कि पेशेंट के बाजू वाली जो पेशेंट है, उसका कोई रिलेटिव या उसका पेशेंट या उसका जो नियर रिलेटिव है, उसकी साइन आपने लेनी है कि द टोटल प्रोसीजर वाज एक्सप्लेन्ड इन फ्रंट ऑफ मी टू दैट पेशेंट, बट पेशेंट वाज नॉट रेडी फॉर एनीथिंग, नॉट फॉर CS, नॉट फॉर कंसेंट, और नॉट फॉर नेगेटिव कंसेंट, एंड नॉट फॉर शिफ्टिंग आल्सो। एंड उसका साइन लेके आपने आपके पास रख देना है। वॉट एवर द कॉन्सिक्वेंसेस हैपन्स, यू आर फ्री, क्योंकि आपने एक प्रूफ तैयार किया है आपके फेवर में, जो भी आपको कोर्ट में आपके साथ में रहेगा, है ना। तो ये दैट इज एडिशनल टिप जो मैंने पीछे दिया था। और सेकंड ओपिनियन लीजिए, मे बी सुप्रिया मैडम को बुला लीजिए कि मैडम आप आइए, और मैडम ने देखना है फाइंडिंग, उसने बोलना है कि नो शी विल नीड सिजेरियन सेक्शन, वो तो कंडीशन है। दो एक्सपर्ट अगर साथ में बोल रहे हैं, तो कोर्ट इज कंसिडरिंग दैट इफ टू एक्सपर्ट आर सेइंग द सेम थिंग, देन इट इज अ साइंटिफिक फाइंडिंग, ऐसा वो पकड़ते थे। ओके। नेक्स्ट सिचुएशन, हैंड प्रोलैप्स का पेशेंट आ गया। अब क्या, हैंड प्रोलैप्स है तो उसको आपको अर्जेंटली उसमें करना ही है। तब मैं ऑब्स्टिक पार्ट नहीं बोलूंगा, डॉक्यूमेंटेशन पार्ट के हिसाब से क्या बोलूंगा, काउंसिल अबाउट कॉन्सिक्वेंसेस एंड डॉक्यूमेंट। उसमें अर्पाल्सी हो सकती है, ब्रैकियल प्लेक्सिस इंजरी है, पूरी हो सकती है, भले वो 6-8 महीने में नॉर्मल पे आ जाए, नहीं भी आ सकता है। 20%, 80% लोगों का आ जाता है, 20% लोगों का नहीं आता है। अब ये 20% में रहेगा, 80% में रहेगा, वी कैन नॉट गारंटी, सो डोंट गारंटी एनीथिंग। आ सकता है, नहीं भी आ सकता है, परसेंटेज बताइए जो भी है उसका, है ना, वो हिसाब से डॉक्यूमेंट कीजिए, उसका साइन लीजिए पेशेंट का, वो समझाया है कि इसके ऊपर विटनेस का साइन लीजिए। अब अगर वो पेशेंट डू नॉट अंडरस्टैंड द लैंग्वेज विच इज रिटन इन द कंसेंट फॉर्म, इंग्लिश में लिखा हुआ है, उसको नहीं समझता है, तो उसमें नीचे एक सेंटेंस लिखिए कि द कंप्लीट प्रोसीजर इज एक्सप्लेन टू द पेशेंट इन हर ओन लैंग्वेज, या तो फिर हिंदी में लिखिए कि उसको हिंदी में, या तो उसकी जो मदर टंग है, जो भी है लैंग्वेज, उसमें समझाया गया है। उसके लिए पेशेंट तैयार है, पेशेंट का साइन लीजिए इफ ही इज अ लिटरेट पेशेंट, एंड इफ ही इज इलिटरेट, वेरी गुड, थंब तो आएगा ही। जो साइन वाले लोग हैं उनका भी थंब इंप्रेशन, बिकॉज वी नेवर नो, पेशेंट में गो होस्टाइल एंड वो बोलेंगे कि ये तो हमने साइन किया ही नहीं है, विनायक सर ने तो जबरदस्ती हमसे कोरा कागज लिखवाया था तो हमने साइन किया नहीं, तो उनकी सिस्टर ने कर दिया साइन, ये हमारा साइन नहीं है। दे कैन डिनाई, बट दे कैन नॉट डिनाई द लेफ्ट थंब इंप्रेशन, है ना। राइट हैंडेड पर्सन का लेफ्ट थंब इंप्रेशन लेना है और लेफ्ट हैंडेड पर्सन का राइट थंब इंप्रेशन लेना है, दोनों का, पेशेंट का भी विटनेस का भी, दे कैन नॉट डिनाई। और अगर पेशेंट इज एजुकेटेड, आस्क द पेशेंट टू राइट हर नेम बिलो द सिग्नेचर, बिकॉज दे कैन नॉट डिनाई द सिग्नेचर हैंड राइटिंग ऑल्सो। ये हमारा हैंड राइटिंग है ही नहीं, हम हैंड राइटिंग एक्सपर्ट को बोल सकते हैं कोर्ट के थ्रू कि प्रूव करो ये इसका हैंड राइटिंग है, वो बोलेंगे हैंड राइटिंग इसका है। अब हैंड राइटिंग उसका है, व्हाट डज दैट मीन, सिग्नेचर भी उसी का है। So this is in favor of doctor. So have a habit of having thumb impression and a name written below the signature by her own handwriting. That is the remedy to save you from the complications. Okay, consent signature of the witness लीजिए, consent for procedure लीजिए, उसको इमरजेंसी सीजरियन सेक्शन वो पेशेंट तो नहीं देगी, उसका रिलेटिव है, उसको लीजिए। इस कंडीशन में आपका ओरल कंसेंट भी चलेगा, कोई प्रॉब्लम नहीं है। बट अगर कुछ कम ज्यादा होता है तो ओरल कंसेंट आपको प्रूव करना बहुत मुश्किल हो जाएगा कोर्ट में। सो हैव अ रिटन इन्फॉर्म कंसेंट ऑफ द नियर रिलेटिव हु इज स्टैंडिंग आउट ऑफ द ओटी एंड लेबर। पीडियाट्रिशियन मस्ट बी प्रेजेंट ड्यूरिंग प्रोसीजर, क्यों, एक स्पेशलाइज ब्रांच है पीडियाट्रिक्स की। बच्चों बाहर आने के बाद में उसको आप नहीं देख सकते हो, क्योंकि आपको पेशेंट का क्लोजर करना है इधर, सो आप इधर देखेंगे उधर देखेंगे। सो हैव अ थर्ड पर्सन हु इज एक्सपर्ट इन दैट ब्रांच। तो पीडियाट्रिशियन आ गए तो आपका एक हल्का हो जाएगा। दूसरी बात, एडिशनल ये सिक्योरिटी है आपको कि वन एक्सपर्ट, अनदर एक्सपर्ट इज देयर टू टेक केयर ऑफ द बेबी, है ना। एंड टेक प्रॉपर कंसल्टेशन ऑफ अदर फ्रेटर्निटी, who can be those fraternities, मे बी न्यूरोलॉजिस्ट, मे बी ऑर्थोपेडिक सर्जन, फ्रैक्चर लग रहा है आपको ह्यूमरस ब्यूमरस का, तो वो कर सकते हो, ठीक है ना। अब कॉर्ड प्रोलैप्स है हैंड की जगह, उसको थोड़ा डिपोजिट करेंगे वेट मॉप से, वजाने में पकड़ के रखेंगे, कॉम्प्रेस नहीं होने देंगे उसको हेड और पेल्विस के बीच में, और ओटी में शिफ्ट करके अर्जेंट ऑपरेशन करेंगे, ठीक है, वो छोड़ दीजिए। अब डॉक्यूमेंटेशन आ गई, सेम डॉक्यूमेंट, काउंसिल अबाउट द कंसिक्वेंस डॉक्यूमेंटेड बोल सकते हो उसमें, signature of witness, consent of procedure, pediatrician must be present during procedure, keep all records। and इसमें एक बात करनी है, रेफर बेबी इमीडिएटली टू NICU इफ नीडेड लिखा है, पर अगर अच्छा भी है तो क्यों, अगर कॉर्ड प्रोलैप्स है उसमें अगर कंप्रेस हुआ रहेगा तो उसको एकदम से रिकवर होने के लिए अपने हॉस्पिटल के से अच्छा माहौल इज इन NICU, दे कैन टेक केयर वेरी गुड वे, दैट्स व्हाई रेफर द पेशेंट टू NICU at least for 24 hours with the pediatrician। then again next situation is प्रीवियस एलएससी। प्रीवियस एलएससी का तो बहुत नाटक है। प्रीवियस एलएससी वो बोलते हैं हमने पिछली बार तो डॉक्टर साहब ने हमको बगैर बताए किया था, अब इस बार नहीं करें। अरे इज दैट प्रोसीजर दैट पिछली बार किया था तो हाँ इस बार नहीं करेंगे, बट पेशेंट डिक्टेट, नो नाउअडेज दे डिक्टेट अस। हम लोग को कोई भी डिक्टेट करता है, ऊपर से पॉलिटिशियन करते हैं, इधर से अप्रूव्ड अथॉरिटी करती है, इधर से पेशेंट करता है, इधर से पॉलिटिशियंस करते हैं। सो वी आर एट सेंटर पॉइंट। ओके, सो गिव ऑप्शन फॉर मोड ऑफ डिलीवरी, CS और टोलैक। आजकल वो पढ़ के हमने पढ़े हैं इस पे नेट पे गूगल पे, उसमें लिखा है उन्होंने, वाईबैक लिखा है या टोलैक लिखा है, तो जरा करना पड़ता है। अरे क्या करना पड़ता है मैन, उसका कॉन्सिक्वेंसेस कौन भुगत देगा। सो काउंसिल ऑल पॉजिटिव एंड नेगेटिव पॉइंट्स ऑफ द मोड्स ऑफ डिलीवरी, इसमें ये हो सकता है, इसमें हो सकता है, इसमें ये पॉजिटिव है, इसमें ये पॉजिटिव, इसमें ये नेगेटिव, इसमें ऑल पॉइंट्स मस्ट बी, दैट्स व्हाई इट इज अ इन्फॉर्म्ड रिटन कंसेंट। इन्फॉर्म मतलब पूरा इन्फॉर्म कर दिया उसको, पॉजिटिव नेगेटिव पॉइंट इन्फॉर्म कर दिया, दैट इज इन्फॉर्म। एंड रिटर्न आज से लिख रहे इसलिए ठीक है, प्रिंट आउट भी निकाल सकते हो उसको, ऐसा नहीं। ब्लैंकेट कंसेंट इज डिफरेंट एंड ये खाली जगह भरा हुआ कंसेंट फॉर्म इज डिफरेंट। व्हाट इज ब्लैंकेट कंसेंट कि मैं डॉक्टर साहब को पूरे अधिकार देती हूँ, उनको जो भी ऑपरेशन करना चाहे कर सकते हैं, कुछ भी हो तो वो जिम्मेदार नहीं रहेंगे, नीचे की साइड, दिस इज ब्लैंकेट कंसेंट, दिस इज नॉट एक्सेप्टेड। वॉट एवर कंसेंट वी आर गिविंग इज उसमें पूरा प्रोसीजर है, उसको सब समझाया हुआ है, वो समझ में आ गया है, उसको लैंग्वेज में समझा है, ये भी नीचे लिखा हुआ है, उसका साइन है। फिर हम क्या प्रोसीजर करने वाले, पेशेंट का नाम, उसका एड्रेस, डॉक्टर कौन है, उसको क्या प्रोसीजर करने वाले, ये भी हम उसको कंसेंट फॉर्म में भर रहे हैं. प्रोसीजर स्पेसिफिक कंसेंट बोलते हैं उसको. लाइकवाइज, सो जस्ट अ मिनट, आई मेक द करंट ऑन फाइन, शिफ्टेड टू इन्वर्टर. फाइन, ओके. तो उसमें ये पॉजिटिव नेगेटिव पॉइंट देना, पर्टिकुलरली स्कार डेहिशंस और रप्चर के बारे में उनको बताना है और उनके ऊपर साइन लेना है. क्योंकि अगर को कल को कम ज्यादा हो गया, बच्चों वहां आईओडी होगा, फ्रेश आईओडी, तो वो बोलेंगे तुम्हारे वजह से हो. हम तो बोल रहे थे सीजर करो, डॉक्टर साहब ने नहीं किया. ये करने के लिए बहुत माहिर है पेशेंट, दे ऑलवेज गो होस्टाइल. सो मैटरनल एंड न्यूनेटल मॉर्बिडिटी के लिए बताना है, मॉर्टेलिटी का भी बताना है परसेंटेज की, प्रॉपर नोट्स ऑफ शॉर्ट इंटरवल. अब इसमें आपको टाइम नहीं है लिखा पढ़ी करने में, तो आप क्या कर सकते हो, आप उसका वीडियो कंसेंट भी लिख सकते हो. आपके पास फोन है, फोन में रिकॉर्डिंग की सुविधा है, या तो आपका सीसीटीवी कैमरा है, उसमें ऑडियो रिकॉर्ड हो रहा है. ये इन सब के सामने आप उसको समझाओ पूरा, ये है ये है ये है ये है ये है. और आप सोचो 5 मिनट और मेरे को बोलो, ये आप वीडियो कंसेंट भी ले सकते हो उसका, ठीक है ना. और सेकंड ओपिनियन इफ नीडेड. जस्ट अ मिनट, आई विल टेक वन कॉल फ्रॉम किरण पांडे मैम. Okay, no, I'll take. Second opinion is needed or is beneficial in such cases. Okay, fine. अरे क्या हुआ, क्यों अटक गया? हाँ, फाइन. अब ये जैकब मेथू केस जो है अपने पास जो हुआ था, तो इट इज वेरी स्टैंडर्डाइज प्रोसीजर केस इन सुप्रीम कोर्ट, और उसका बहुत आधार है हम लोगों को. क्यों? उसमें फाइनल वर्डिक्ट जो निकला था उसमें लिखा था कि सो लॉन्ग एज अ डॉक्टर फॉलोज अ प्रैक्टिस एक्सेप्टेबल टू द मेडिकल प्रोफेशन ऑफ दैट डे, he cannot be held liable for negligence. मतलब कि एक प्रूडेंट डॉक्टर एक सिंपल सी नॉलेज के हिसाब से अगर पेशेंट को फॉलो करता है, प्रोटोकॉल फॉलो करके ट्रीटमेंट करता है, तो रिजल्ट कुछ भी रहे, उसने ट्रीटमेंट अगर प्रॉपर किया है तो ही इज नॉट नेग्लिजेंट. ये जैकब मेथ्यूस केस ने अपने को, हम लोगों को दिया है. दैट इज वेरी हेल्पफुल फॉर ऑल ऑफ अस. ओके, if there is a charge against a doctor, what are the remedies? Confirm checklist were correct. आपने पूरा प्रोटोकॉल किया था, सब काउंट बराबर था, इंस्टेंट बराबर था, एवरीथिंग. एक्सप्लेनिंग द रिलेटिव इन साइंटिफिक, उनको समझाओ कि हो सकता है ये था ये था ये था. वो सुन सकते हैं, सुन भी नहीं सकते, 50-50% है. अगर वो कुछ एजुकेटेड होंगे तो सुनेंगे, अब उनको पैसा दिख रहा होगा बिल का तो नहीं सुनेंगे. आउट ऑफ कोर्ट सेटलमेंट कैन बी एन ऑप्शन. अब इसमें क्या है कि उनको केबिन में बुला के लाख रुपए दे दिए और बाद में वो आएंगे, ऐसा मत सोचो. ये आज लाख रुपए लेके जाएंगे, 2 महीने के बाद भी फिर से आएंगे, फिर से लाख रुपए मांगेंगे. सो दैट कैन नॉट बी अ रेमेडी. सो व्हाट इज अ रेमेडी देन इन आउट ऑफ कोर्ट सेटलमेंट? देयर इज अ लोक अदालत एट एवरी डिस्ट्रिक्ट प्लेस. देयर इज अ रिटायर्ड डिस्ट्रिक्ट जज. यू गो टू द जज, दे विल लिसन टू योर साइड, दे विल लिसन टू द पेशेंट साइड, और वो एक कॉम्पेंसेशन का अगर निगलेंस है तो डिसाइड करेंगे. आप बोलेंगे चलो ह्यूमैनिटरी ग्राउंड पे हम देना चाह रहे, तो वो डिसाइड करेंगे और आपके पैसे आप कोर्ट में जमा करेंगे. कोर्ट के थ्रू द पेशेंट विल गेट द कॉम्पेंसेशन. वंस दे गेट द कॉम्पेंसेशन थ्रू कोर्ट, देयर विल बी अ डिक्री, ऑर्डर रहता है कोर्ट का, एंड आफ्टर दैट डिक्री, आफ्टर दैट ऑर्डर, पेशेंट कैन नॉट सू यू और पेशेंट कैन नॉट टेक यू टू एनी कोर्ट इन दिस वर्ल्ड. आपके अगेंस्ट वो किसी कोर्ट में कंप्लेंट नहीं कर सकता, किसी पुलिस स्टेशन में कंप्लेंट नहीं कर सकता. सो दैट इज बेस्ट ऑप्शन इज लोक अदालत, आउट ऑफ कोर्ट सेटलमेंट. नहीं तो क्या है, फिर कोर्ट केस, लॉयर्स, चार्ज रेंजिंग फ्रॉम 10 लाख 40 लाख मे बी मोर. इसमें एक डेंजरस चीज ये है आजकल की, नो विन नो फीस बेसिस इज देयर. ये यूरोप में था, पहले अमेरिका में था, अभी अपने पास आया हुआ. व्हाट इज नो विन नो फीस बेसिस? अगर पेशेंट का जो वकील है वो पेशेंट को बोलता है कि अगर हम केस नहीं जीतते हैं तो फीस मत देना, अगर जीतते हैं तो 10% फीस मुझे दे देना, मे बी 10-20 वॉट एवर दे डिसाइड. ये कितना डेंजरस है. पेशेंट बोलता है अरे साल नुकसान तो कुछ भी नहीं है, चलो डाल दो केस. ऐसा करेंगे तो पूरे डॉक्टर लोगों पे केस होगी. वैसे भी जितने भी सीपीए के केसेस चल रहे हैं उसमें 80% तकरीबन 70 to 80% गायनेकोलॉजिस्ट पे ही, बाकी लोगों पे नहीं है. सो दिस इज द सिचुएशन. अपने पास कुछ भी टेढ़ा मेढ़ा होने को टाइम नहीं लगता. सो ये है. और डॉक्टर्स मस्ट हैव अ स्ट्रांग मेडिकल इंडेमनिटी. मेडिकल इंडेमनिटी का बहुत बहुत अलग किस्सा है. उसमें क्या है, वो बोलते कि सर ऐसा ऐसा है, करो साइन, हम लोग साइन करते हैं आंखें बंद करके. नो, आप उसमें रीड कीजिए कि व्हाट आर द पॉइंट्स दे हैव मेंशन्ड. एटलीस्ट 2-3 इंसिडेंसेस का उसमें इंडेमनिटी कवर होना चाहिए, एटलीस्ट 1 करोड़ का होना चाहिए आजकल के हिसाब से. एंड मोर ओवर योर स्टाफ मस्ट बी कवर्ड इन दैट इंडेमनिटी, क्योंकि क्रिमिनल लायबिलिटी है. आप सिस्टर ने गलत इंजेक्शन दे दिया, पेशेंट मर गया, तो वो क्रिमिनल रिस्पॉन्सिबिलिटी जो पेशेंट की अपना ये सिस्टर की है वो उसी के साथ रहेगी, वो आपके पास ट्रांसफर नहीं होगी. आपके पास क्या ट्रांसफर होगी, सिविल लायबिलिटी ट्रांसफर हो सकती है, कॉम्पेंसेशन आपको देना पड़ेगा। आपको वाइकेरियस लायबिलिटी है, हॉस्पिटल का मालिक होने के हिसाब से आपको कॉम्पेंसेशन देना पड़ेगा। पर क्रिमिनल लायबिलिटी शिक्षा तो उसी को होगी, जो उसको पनिशमेंट होनी चाहिए वो सिस्टर, वो उसका जो कॉम्पेंसेशन है तो आपको किसी में से भरना पड़ेगा। क्योंकि इंडेमनिटी वाले क्या बोलेंगे, नहीं नहीं डॉक्टर साहब हमने तो आपको कवर किया था, आपके स्टाफ को नहीं कवर किया था। सो सी टू इट दैट योर स्टाफ इज ऑल्सो कवर्ड इन इंडेमनिटी while taking the policy, ये मेरा कहने का मतलब। सो while taking the medical indemnity कीजिए। दूसरी बात, आपके ऊपर जब भी केस हो तो ask the court to make the insurance company a party, क्योंकि अगर उनको पार्टी नहीं करते तो बहुत सारी बार वो कॉम्पेंसेशन नहीं देते हैं, है ना। तो क्या मतलब है फिर, अगर आप 1 करोड़ का इंश्योरेंस निकाले है, उसको 10-20 हजार हर मंथ को आप ये दे रहे हो, आपका हफ्ता दे रहे हो पॉलिसी का, तो उसके बावजूद भी अगर वो अपने कुछ काम के नहीं है तो ये कर सकते हैं वो पॉलिसी वाले। तो इसलिए उनको पार्टी बनाइए और उनसे कॉम्पेंसेशन लीजिए। ओके, सो नेक्स्ट 304A एक सेक्शन है अपने पास लगेगा। 304A इज अ डेथ बाय निग्लिजेंस, उसमें 2 साल तक की सजा हो सकती है। अब इसमें से ए अगर निकल गया, पुलिस वाले कभी कभी करते हैं ये नहीं लिखते, सिर्फ 304 लिखते। 304 ये कल्पेबल होमिसाइड, मर्डर का केस है, अनप्लान्ड मर्डर का, उसमें 7 साल तक की सजा हो सकती है। तो ये लिखना बहुत जरूरी है। कभी भी आपके ऊपर कोई चार्ज लगता है तो देखिए कौन सा सेक्शन लगाया और वो अपने वकील को बोले ये लगाया। डिफेंस ऑफ डॉक्टर, कॉन्ट्रीब्यूटिव नेग्लिजेंस मैंने बताया, ड्यूटी डिस्चार्ज अकॉर्डिंग टू प्रिवेलिंग स्टैंडर्ड वो भी बताया, एरर ऑफ जजमेंट व्हिच विल नॉट हेल्प इन, एरर ऑफ जजमेंट इज डिफरेंस एंड मिसडायग्नोसिस इज डिफरेंट। 2 सिंपल से डायग्नोसिस से आजू बाजू में है, थोड़ा मिस कर गए, दैट इज एरर ऑफ जजमेंट, दैट इज एक्सेप्टेड बाय लॉ। क्योंकि आप बुक में दे सकते कि देखिए ये विलियम्स में ये दिया है या एरीज में ये दिया है, ये एरर ऑफ जजमेंट हो गया। पर अगर मिसडायग्नोसिस है, पेशेंट आपने शिफ्ट कर दिया लेबर रूम से रिकवरी में, 2 घंटे उसको देखा ही नहीं, पेशेंट पीपीएच में गया, वहां ब्लीडिंग हो रहा है, शॉक में गया, किसी ने देखा नहीं, सो दैट इज नॉट एरर ऑफ जजमेंट, दैट इज अ मिसडायग्नोसिस एंड मिसमैनेजमेंट। तो वहां तो 100% नेग्लिजेंस है। So what are the precautions against negligence? Obtain last few slides. Obtain written informed consent, develop good rapport with the patient and relatives, keep full legitimate record and never guarantee a 100% cure. So this is 100% cure certificate दिया है, किसी क्वैक ने दिया है, BISM. So अपना कोई देगा नहीं ऐसा, complication system, proper documentation, keep blood ready if patient is negative. Patient negative है तो आपका एक ब्लड आपने रेडी रखना ही है, वॉट एवर द रिजल्ट। कुछ नहीं हुआ, नॉर्मल हो गई, शिफ्ट कर दिए, सब हो गया, वो ब्लड कैंसिल कर दो, पर एक तो कम से कम रखो, दैट विल हेल्प यू इन वेरी गुड टाइम। ऑलवेज कीप अ पैरेलल सिस्टम रेडी, क्योंकि आपका एक कलिक रेडी रखिए, एक सिस्टम रखिए, हॉस्पिटल रखिए स्टिपुलेटेड कि अगर ये हो जाए तो मैं कहाँ लेके जाऊँ। बीच में एक सुप्रीम कोर्ट ने एक वर्डिक्ट दिया था कि एक डॉक्टर ने ऑपरेशन किया, पेशेंट सकम हो गया, सकम मतलब अरेस्ट में गई उसने, तो उसने वहां रिसेट किया पेशेंट को, वहां आईसीयू नहीं था तो शिफ्ट करना पड़ा। तो शायद सुप्रीम कोर्ट या शायद हाई कोर्ट, आई कुड नॉट रिकॉल दैट, बट उन्होंने दिया कि अगर ये कंडीशन में इन्होंने करना है तो ऑपरेशन नहीं करना चाहिए इन्होंने। तो उस वक्त ये चर्चा चली थी कि एवरी हॉस्पिटल शुड हैव अ आईसीयू, व्हिच इज नॉट पॉसिबल एंड कोर्ट हैज नॉट सेड लाइक। कोर्ट ने एक सजेशन दिया था कि हॉस्पिटल में आईसीयू रहा तो अच्छा रहेगा। तो क्रिटिकल पेशेंट करते वक्त आपको अगर आईसीयू सेटअप में करे, ऑब्स्टेट्रिक आईसीयू सेटअप में, तो दैट विल बी बेटर थिंग। सो नॉट पॉसिबल इन एवरी टाइम। सो ये इस तरह की इन्फ्रेंस निकल सकते हैं, और हर बार कोर्ट कोई बोलता नहीं कि ये वो है। कोर्ट के भी बहुत सुझाव अच्छे रहते हैं, पर उस सुझाव को कुछ लोग उसका गलत मतलब निकालते हैं। तो इस हिसाब से गलत मतलब निकला था कि हर हॉस्पिटल में आईसीयू होना जरूरी है। दैट वाज नॉट द कोर्ट डिसीजन। ओके, सजेशन था कि हुआ तो अच्छा रहेगा, वो अलग बात। अब डॉक्यूमेंटेशन अबाउट फॉलोड ऑल प्रोटोकॉल प्रोटोकॉल, ये तो मैंने आपको पूरा बता दिया, फिर रिपीट करने की जरूरत नहीं। सो व्हाट इज टेक होम मैसेज? प्रोटोकॉल, डॉक्यूमेंटेशन, ट्रेन स्टाफ, ट्रेनिंग एंड ड्रिल्स। पीपीएच का पेशेंट आया तो ड्रिल्स कराओ। अब सीजर है, अब उसको अभी सर ने बताया कि 2 फोर्सेप्स लगाने हैं, तो आइन सिस्टर फोर्सेप का ड्रम लो। अब सर मैं नहीं हूँ, फोर्सेप का ड्रम किधर है मुझे नहीं मालूम। यू विल गो मैड एट दैट मोमेंट, नो, अरे ये इसको किसने बुलाया यहाँ पे लेबर रूम में, तो अपना दिमाग खराब होता है। इसलिए उनका ड्रिल और ट्रेनिंग बहुत जरूरी है। ओके, हैव अ सिस्टम इन हॉस्पिटल वर्किंग कि ओटी चालू है तो सिस्टर चेंज नहीं होगी, लेबर रूम चालू है तो सिस्टर चेंज नहीं होगी, जो भी वॉट एवर प्रॉपर सिस्टम होनी चाहिए, तो आपके दिमाग को तकलीफ कम होगी। एंड कीप गुड रिलेशन विद योर कलीग्स, दे आर द पर्सन हु विल हेल्प यू इन एवरी कंडीशन, उनके साथ में। एक एडिशनल स्लाइड मैंने डाला हुआ है, डिफरेंस बिटवीन एमटीपी एंड पीसीपी एनडीटी. वन कंसल्टेंट में हैव मेनी सेंटर्स फॉर एमटीपी विच इज नॉट पॉसिबल फॉर पीसीपी एनडीटी. 2 ही सेंटर रख सकते हैं आप. वन में परफॉर्म एमटीपी एट एनी रिकॉग्नाइज्ड सेंटर. मैं सुप्रिया जी के हॉस्पिटल में जाके एमटीपी कर सकता हूँ क्योंकि मैं क्वालिफाइड हूँ. पेशेंट इज प्रॉपर, वो 5 इंडिकेशन में बैठता है एंड मैडम का सेंटर भी रिकॉग्नाइज है, तो मैं जाके कर सकता हूँ. अगर स्टेट के बाहर जाता हूँ तो वहाँ के लोकल स्टेट के अथॉरिटी को इन्फॉर्म करना है जस्ट, नहीं तो पूरे इंडिया में आप कहीं भी एमटीपी कर सकते हैं. नो रेगुलर इंस्पेक्शन मेंशन लॉ फॉर एमटीपी सेंटर्स. जो हर 3 महीने को पीसीपी एनडीटी बोला है वो एमटीपी में नहीं है. नो रिन्यूअल फॉर एमटीपी. एमटीपी का एक बार आपको रजिस्ट्रेशन मिल गया, लाइफ लॉन्ग है. पीसीपी एनडीटी के साथ 5 साल में रिन्यूअल नहीं है. पीसीपी एनडीटी का 5 साल में रिन्यूअल है, उसको 50% फीस है, वो जो एमटीपी में नहीं है. नॉन बेलेबल मतलब क्या? आपको बेल मिलेगी पर कोर्ट से मिलेगी. बेलेबल में आपको चौकी से मिलती है बेल. कॉग्निजेबल means what? The investigating officer may start investigation without court's order or he or she may arrest the doctor. ये तो cognizable में हो गया. और non compoundable means once case started it has to get ended by the court only. वहाँ रिटर्न वॉल नहीं है. एक बार केस चालू हुए तो खत्म ही करनी पड़ेगी. हमने हम आपस में निपटा लिए है, अभी आउट ऑफ कोर्ट सेटलमेंट हो गया, ऐसा नहीं होता है एमटीपी में. ओके, पीसीपी एनडीटी में भी वही है. और रिगरस इम्प्रिजनमेंट 2 to 7 years विद फाइन और विदाउट फाइन. सो काइंडली सेव माय नंबर. भगवान से प्रार्थना करता हूँ किसी पे भी ये नौबत ना आए. पर अगर आपको एडवाइस चाहिए कि अभी बहुत सारे कॉल आते हैं मुझे रोज, कम से कम एक तो कॉल आ ही जाता है कि सर मेरे पास पेशेंट आया था, उसने एमटीपी करके गया, 21 साल का, अभी इंस्पेक्टर का फोन आया था कि उनकी झगड़े है और आपको ये रिकॉर्ड देना पड़ेगा, क्या करूं? ये कहाँ दिया है लॉ में कि देना है नहीं देना है? तो मैंने उनको बता दिया कि नहीं, देखो, वो इन्वेस्टिगेटिंग ऑफिसर है, ये कॉग्निजेबल ऑफेंस में उनको अधिकार बनता है कि दे कैन डिमांड द डॉक्यूमेंट. आप डॉक्यूमेंट का अगर वो मांगते हैं रिटर्न फॉर्मेट में उनसे एप्लीकेशन लो कि मुझे डॉक्यूमेंट दो, क्योंकि कॉन्फिडेंशियलिटी है एमटीपी की, वो आप ब्रीच नहीं कर सकते. आपने अगर ब्रीच की तो आपको 1 साल की सजा है उसमें. तो उनको एक रिटर्न फॉर्मेट में लेना है इन्वेस्टिगेटिंग ऑफिसर का पुलिस से, और अपने आपके पास रखना है. पेपर की पूरी झेरॉक्स करो और फोटो कॉपी के ऊपर नंबर डालो, कितने पेपर दिए उनको हैंड ओवर करो, उनसे रिसीव्ड ले लो आराम से. अभी छोटी छोटी जो चीजें हैं इसके लिए भी आई एम अवेलेबल. यू कैन कॉल मी एट एनी मोमेंट. हैव अ फोटोग्राफ ऑफ दिस स्लाइड. काइंडली सेव माय नंबर. अगर आपने नंबर सेव कर ले तो आपको मेरे फोन के ऊपर से जो टिप्स जाते हैं ब्रॉडकास्ट ग्रुप में वो मिल ही जाएंगे. एंड दिस इज माय complete address, and this is completely free of cost since 18 years, and it will be free of cost forever. So this is women empowerment Israel, this is women empowerment India. Salute to the army, to the Dr. Captain Deepika Chetri, State of Our Unit, and gun for the nation. Salute for these women. 160 करोड़ डोसेस लग चुके हैं अब तक. तो देखो कितने बैड कंडीशन में वर्क करते हैं. सैल्यूट. एंड this is my humble request. Kindly vote for me for the Vice President West Zone Foxy, which will start voting from 21st of this March and 30 March तक है. Please मुझे vote कीजिए and send me to Foxy. Thank you very much. So when they can stay together, why can't we? So stay together, help your colleague, that the colleague will help you in your bad situation if something goes wrong. Thank you very much. Again, thank you Patna OB-GYN Society for giving me the chance.
Thank you, sir. Dr. Swapna Jindal is there.
Dr. Vandana.
Dr. Swapna Jindal is also there.
Thank you, Dr. Ajay.
A
mesmerizing talk, I would say that. And thanks for your help that you have been giving this for the last 18 years, and you promised that you will continue for the whole life. Small tips, very, very important. And I think nobody has anything to add to it. We can all just say thanks and thanks. That's all. And thank you again to Patna Society for organizing this wonderful webinar and including such a wonderful topic. Thank you so much.
Thank you.
Dr. Sapna, do you want to add something? Please unmute yourself. You are muted. Yes.
Thank you very much, sir. We are very thankful to you for guiding us all the liberal and all the laws and about the consent form and time. You said in previous talk, you said we should write the time also.
Yeah.
What moment you are doing that? You have
See, below your signature, have a habit of putting the date and time of your signature. That will help.
yeah, date and time, sir. Thank you, sir.
Yes,
This is
yes. Thank you very much. Thank you. You all are president secretaries. Make aware you are all members about all these medical legal things. Thank you.
Thank you so much, Dr. Ajay Mane, for your wonderful presentation. Such an excellent and your important inputs. I think delegates must be feeling so confident that most of the things that you have presented about consent and counseling and paper keeping work, that they are feeling good, that most probably they'll be saved from most of the medical legal problems. So thank you for that. And thank you both the chairpersons, Dr. Vandana and Dr. Sapna, for sparing your time and giving your inputs.
Thank you,
And
ma'am. Thank
all
you.
the best, Dr. Ajay Mane, from I think from everyone, I must say, because everyone is
From all of us also, Dr. Ajay, and we promise our support and vote, both of them.
Yes, yes. Thank you, Vandana madam. Thank you, Sapna ma'am and Nevaji. Thank you very much.
sir, all the best for
Kindly tell
election.
to all members of your society.
Yeah,
Sure,
sir.
sure.
Thank you. Thank you. Thank you.
Okay. So after this mesmerizing session, we move on to the third scientific session, that is about adolescent health issue. Such an practical aspect because we are facing every day the adolescent health problems with obesity, like teenage pregnancy, mental health problem, and many more. So to present this topic, we have none other than our own secretary, Dr. Supriya Jaiswal. And we all wish you best, Supriya, for your upcoming election. To chair this important session, we have two eminent chairpersons. First, I wish to invite Dr. Meena Samant, who needs no introduction. She is a very active member of our society. At present, she's a senior consultant and HOD Kurji Holi Family Hospital, Patna. And she is chairperson Foxy Clinical Research Committee 2019-21, Secretary General of ISOPAR. She was Vice President POGS 2019-20, Secretary Patna POGS 2017-19, and she did Kamini Rao Oration in 2005. She was Organizing Secretary of Yuva Fox in 2011, the Organizing Secretary Boxcon in 2018, a DNB teacher, and she, to her credit, there are many publications in reputed journal and chapters in many books. So welcome, Dr. Meena. And then to add her, the chairperson, Dr. Monica Gupta. Monica Gupta is a professor at VMCC Safdarjung Hospital, New Delhi. She is a fellow UK of urogynecology and pelvic reconstructive surgery. She has special interest in urogynecology, critical care obstetrics. She is secretary AOGD Foxy Delhi Society 2021-22. And to her credit, there are many awards, Kamini Rao Yuva Foxy Oration Award, and many others. So welcome, Dr. Monica Gupta. So over to chairpersons to conduct this session. So may I request Dr. Meena to invite and introduce our own speaker, Dr. Supriya Jaiswal. Dr. Meena. Dr. Meena, are you there?
Ma'am, I think so. There is a connectivity problem, and Dr.
Okay,
Meena.
so then I may request Dr. Monica. Is she there?
She was right from the beginning, but then she had some family emergency. She called me up just now.
Monica.
Yeah,
so,
yeah.
Supriya Jaiswal, she needs no introduction.
I've been introduced.
You have been introduced, right. So our sweet, active, dynamic secretary, Dr. Supriya Jaiswal, is before you to present adolescent health issues.
Ma'am, Meena ma'am joined, ma'am, just now.
Okay, Dr. Meena. Cannot see her.
Hello. I know my this thing net is creating a lot of problem.
Okay. Meena,
So
I
I'm
think
trying to join with my other.
I think
Can you hear me?
yes, but your voice
Thank
is
you,
cracking.
Dr. Vinita and Dr. I'll do the concluding. Yeah.
Yes.
Okay.
Yes.
Yeah, I think I will conclude later on. By that time, I will join to another. Yeah.
Okay.
Okay,
Okay,
Dr.
shall I-
Meena. So I request Dr. Supriya Jaiswal to start with her talk.
Yeah, shall I
Yeah,
share my screen?
Dr. Supriya has been introduced because I was lost for some
Yeah.
time.
Can you see? Can you
Yes,
see?
yes, Supriya.
Yes, ma'am.
Well
Yes.
seen.
Okay. So a very good evening to all of you, all the viewers, the faculties on the virtual dais now. So I'm going to talk on the adolescent health issues, the latest concerns. What are the latest concerns? Actually, I need to say the youth of today are the leaders of tomorrow. Adolescent is a process of growing. Well, WHO defines adolescent as an individual between 10 to 19 years of age. So, India is one of the most populous countries in the world, and adolescents constitute about 1/5 of India's population. Young people constitute about 1/3 of the total population. So, we have lot many of adolescents. Focusing on their characters, adolescence means aggressive, anemic, abortion, dynamic, D for dynamic, developing, depressed. These are the few features that usually we encounter with adolescents. O is overconfident, overindulging, obeys. L means loud but lonely and lack of information, enthusiastic, explorative, and experimenting. Social, sexual, and spiritual, courageous, cheerful, and concerned. Nervous, never say no to peers. This is very important for them. Peers are very important to the adolescents. And temperamental, teenage pregnancy. What happened? Something happened, so it's not getting. One second, can I stop share and start once again?
Yes.
One sec. Is it full screen?
No, it's not full screen. Yes, it's full screen now. You can go ahead, Supriya.
Oh, but then it is not helping me now. It's giving me trouble actually.
So you can go with the side slides also. It's full screen now. It's not moving.
No, something is wrong here. I don't know. So I'll move ahead with that small share only.
Yes, that was also quite okay.
Actually, it was well planned, but somehow it happens at the main time, no? So only half is she, no?
No, but it's quite okay. It's almost 2/3.
Okay.
Now full screen, ma'am.
Now it's full screen.
So, primary dysmenorrhea. This is the most common issue that the adolescents they face. Painful menstruation in the absence of pelvic pathology. It begins with adolescents when they attain anovulatory cycles. Pathophysiology is related to prostaglandin and leukotriene secretion. Higher urinary leukotrienes levels have been found in such menstruating girls. Then secondary dysmenorrhea is painful menses due to pelvic pathology or a recognized medical condition. Most common cause of secondary dysmenorrhea is endometriosis. So pelvic imaging and ultrasonography, regardless of this, they diagnose this disease. Any obstructive anomaly of the reproductive tract, whether vaginal or Mullerian, can cause secondary dysmenorrhea. Then there is some problem. I don't know that happened this today.
No, it's moving.
So let me move like this only.
Yes.
So this is the approach to the adolescent dysmenorrhea. So once you diagnose all the reasons why she is having this dysmenorrhea, they does not respond to therapy. First of all, you start with the NSAIDs, hormonal therapies. This is the regular chart that usually we any gynecologist go for once our adolescent has come for with dysmenorrhia. Now, coming to AUB in adolescents is a very known fact. FIGO classification, everybody knows this palm coin classification. That palm stands for polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. And coin stands for coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, not yet classified. So, etiology of adolescence causes of abnormal uterine bleeding will primarily present as a result of these non-structural causes. So, AUB in adolescents, it is a fact that heavy menstrual bleeding is the most frequent clinical presentation of AUB. And ovulatory cycles owing to immature hypothalamic pituitary ovarian axis is a leading etiology of heavy menstrual bleeding, and there is an accompanying bleeding disorder in almost 20% of patients with HMB. Endocrine disorders such as hypothyroidism, hyperprolactinemia, and polycystic ovarian syndrome are possible causes of AUB. So, exclusion of bleeding disorders, especially of von Willebrand's disease, is important for diagnosis and treatment of HMB, particularly in the case with AUB, which has been present since menarche. So, now coming to treatment, it is hormonal and non-hormonal. So, both sides, it's very commonly used. These NSAIDs, tranexamic acid, desmopressin, these things are most commonly used. Then combined oral contraceptive pills. This use may decrease bleed, uh, BMD, sorry. So this is BMD in adolescents because this affects the bone mass, especially in those choosing very low dose formulations. Patients may often experience nausea with increased dosages of estrogen, and therefore an antiemetic can be administered before the patient receives the dose of oral contraceptives. But there is really some trouble. I don't know. So urban versus rural PCOS. See, PCOS is very common in urban areas because the lifestyle changes are more in urban. Their lifestyle is very different in urban than in rural. So more cases of PCOS we see in urban places. So all three elements of the Rotterdam criteria should be present in teenagers to make the diagnosis of PCOS. Oligomenorrhea or amenorrhea, then polycystic ovarian morphology, and hypoandrogenemia. So these are the management protocols of the PCOS in adolescent. You have to first assess the history of the patient, cognitive behavioral assessment, go for the dietary counseling, exercise, pharmacotherapy, and others. Teenage pregnancy is painful, but true facts. Approximately 12 million girls between 15 to 19 years of age and girls under 15 years give birth each year in developing regions. At least 10 million unintended pregnancies occur each year among adolescent girls between 15 to 19 years of age in the developing world. Complications during pregnancy and childbirth are the leading cause of death for these girls. Of the estimated 5.6 million abortions that occur each year among adolescent girls 15 to 19 years, 3.9 million are unsafe, contributing to maternal mortality, morbidity, and lasting health problems. Teenage pregnancy in developed countries is usually outside of marriage. Teenage pregnancies in developing countries are a result of early marriages. So early marriage is the main culprit for teenage pregnancy in India. So there are multiple risk factors of early pregnancy: social deprivation, lower socioeconomic growth, low education achievement, then having had teenage parents, poor transition from school to work at 16 years of age, sexual abuse, mental health problems. Then antepartum complications are there in pregnancy-induced hypertension, nutritional deficiency, anemia, sexually transmitted diseases like STIs, alcohol and substance misuse, and smoking. Intrapartum, preterm labor, prolonged labor, obstructed labor, and birth injuries in these teenage girls. Postpartum, postnatal depression, and difficulties with breastfeeding are always encountered. So, termination and adoption are options that should be available to pregnant teenage girls. Antenatal care should be tailor-made to the individual needs of this group, particularly with regard to encouraging early and regular antenatal attendance, smoking cessation programs, counseling regarding the risk of STIs, social support, institutional deliveries, and future contraceptions. So primary prevention focuses on sex education in schools, child and youth development programs that seem to be particularly successful if combined the following elements like learning support for those who are struggling academically, relationship skill development, prenatal involvement, support for those experiencing family background and conflict. Then secondary prevention focuses as mandatory and directed at teenagers who are already sexually active through the use and provision of contraception. Combined use of condoms plus the contraceptive pill is probably the most effective option. So now sexually transmitted diseases are very common. So keep calm and say no to STIs. So this is an tip of the iceberg that you can see the health consequences and impact of STDs on HIV transmission. It is a great economic burden on the society. Other health problems are like physical inactivity, nutrition health, mental health, accidental and intentional violence, substance abuse, sexual abuse in adolescents. You can see in 20th century adolescents and 21st century. So they used to play, but the 21st century adolescents are more prone to indoor games and a very lazy type of lifestyle. So the obesity has WHO ranked physical inactivity as the fourth most important risk factor for global mortality, accounting for 5.5% of death worldwide. There is a strong association between increased level of physical activity and improved objective health outcomes. Yeah. So these are the reasons for the physical inactivities, that several environmental factors which are linked to urbanization discourage people from becoming more active. Then consequences of physical inactivity leads to energy imbalance and overweight or obese. Increase the risk of factors that cause cardiovascular risk, including hyperlipidemia, high BP, obesity, insulin resistance, and glucose intolerance. Increase the risk of developing type 2 diabetes, increases the risk for developing breast, colon, endometrial, and lung cancers. So lead to low bone density, which in turn leads to osteoporosis. Now, WHO recommendation, children and youth aged 5 to 17 should indulge themselves in at least 60 minutes of moderate to vigorous exercises. Amounts of physical activity greater than 60 minutes provide additional health benefits. Most of the daily physical activity should be aerobic. Vigorous intensity activity should be incorporated, including those that strengthen muscle and bone at least 3 times per week. For this age group, bone loading activities can be performed as part of physical games, running, turning out or jumping. So the nutrition, 47% girls and 58% boys were thin. So this was the data given, 56% girls and 35%. This was that because this all shows poor nutrition in the adolescents. Now coming to the mental health. In India, suicide among adolescents is higher than any other age group. That is 40% of suicide deaths in men and 56% of suicide deaths in women occurred in 15 to 29 years of age adolescents. The prevalence rate of child and adolescent psychiatric disorders in the community has been found to be 6.46%, and in schools it was 23.33%, and the reporting system of psychiatric disorders in children were found to be inadequate. Then accidents, very common in the adolescents. So accidental deaths due to unintentional injuries constituted 20% of the total deaths in 5 to 29 age groups. And 77.5% of adolescents are at risk behavior. Risky behavior ignores traffic rules, leads to road traffic accidents and deaths, as reported in a study from Delhi. Now coming to substance abuse, about 11% of adolescent boys and 1% of adolescent girls consumed alcohol. In that, 3% consume it daily. About 28% boys and 4% girls use some kind of tobacco. Average age at tobacco use initiation was earliest at 12 years and alcohol at 13 years among adolescents. About 11% of cannabis users were introduced to it before the age of 15. That is really very unfortunate. Sexual abuse, millions of children and adolescent girls across the globe are subjected to sexual abuse, including sexual assault or rape. A 2011 study estimates that 18% of girls and 8% of boys worldwide have experienced sexual abuse in their lives. This is a major public health problem and a grave violation of human rights. Healthcare providers have an important role in identifying abuse and providing child, adolescent-centered care to disclosure of abuse and in connecting survivors to other services that they may need. Now, coming to all the programs that for adolescents there are in India, that is Kishori Shakti Yojana, Balika Samriddhi Yojana, Sabla, Rashtriya Kishori Swasthya Karyakram, Adolescent Reproductive Sexual Health Programs, and POXO. So these are the target population and unmarried adolescent girls for 11 to 18 years whose family's income is below 6,400 per annum. So services provided are educational activities through non-formal and formal literacy pattern, immunization. These are the yojanas for these people. So then there are Balika Samriddhi Yojana, then Sabla. These are the different yojana projects of government to help the adolescents, to empower the adolescent girls. Coming to Rashtriya Swasthya Karyakram, key principles of this program is adolescent participation and leadership, equity and inclusion, gender equity and strategic partnership with other sectors and stakeholders. Objectives is to improve their nutrition, improve sexual and reproductive health, enhance mental health, prevent injuries and violence, prevent substance misuse. Then we have adolescent reproductive sexual health. Here also their strategy has been designed to facilitate adolescent services at key delivery points of the public health system in the country. The strategy incorporates a core package of services including preventive, promotive, curative and counseling services. Now coming to POXO, this is very important. POXO of Protection of Children from Sexual Offense Act 2012, a comprehensive law to provide for the protection of children from the offenses of sexual assault, sexual harassment, and pornography, while safeguarding the interest of the child at every stage of the judicial process by incorporating child-friendly mechanism for reporting, recording of evidence, investigation, and speedy trial of offenses through designated special courts. So young people are the world's greatest untapped resource. Adolescents can be key driving force in building a future of dignity for all of us. So take care of your adolescents, and rightly said, I'm very much passionate about adolescent health. Thank you for your patient hearing, for your attention. Thank you very much.
Thank you, Dr. Supriya. That was such an excellent presentation, and your passion for all the adolescent health issues. I know you're going to go a long way and contribute a lot in this direction. Wish you all the very best for your forthcoming elections, and we wish to see and hope to see a long innings by you. Then you said it's all the recent things about this adolescent health you want, and I think that was, you've done justice. One thing that I wanted to include here is regarding the psychological health, mental health as well, because even though they are aggressive, they are a very trying to achieve, they do indulge in drugs, you mentioned that, but then we also hear off and on guys and girls going in for suicidal attempts, and also into depression and all kinds of. So I think we need to be really sensitive on those issues as well. And it's something not only for the adults that they face those psychological stresses, even our youngsters do that. So we need to address that in a very sensitive way. So thank you. And in fact, I was there in the link, but it was the viewers link. I listened to both the talks, they both previous to yours, including yours. All were fantastic and so many learning points. And it's a mixed bag in real sense, people from all mixtures of our country, states, and topics as well. And the next one is even topic wise and in a different direction. So thank you. It's a beautiful program.
Thank you, Dr. Meena. Thank you very much.
Thank you, Dr. Supriya, for your wonderful presentations. You beautifully explained all the problems of adolescents and how to manage them. And thank you, Dr. Meena, for your input, adding the points. So that's the end of wonderful third session. And we all wishing Dr. Supriya best for your election. So good wishes. So moving to the last session, this is the last, but one of the most topic, PCOS and infertility. As we all know, PCOS is one of the most common cause of infertility, but the good thing is that we can manage it if we manage it properly. To present this important topic, we have a well-known IVF specialist from Delhi, Dr. Shivani Sachdeva. Shivani Gaur, I can see here. Okay. To chair this session, we have our own Dr. Amita Sinha, a very active member of our society. She's active in all societies of our state. So welcome, Dr. Amita. To introduce you, she is a consultant gynecologist at Patna and member Executive Committee POGS, Executive Committee member of ISOPAR National, is Zone Coordinator, Clinical Research Committee, FOXY 2019-21.
Thank you, Nibadi. Thank you.
Next. And area of interest of yours is high-risk pregnancy, colposcopy, and safe motherhood. So welcome, Dr. Amita. And now I wish to invite the other chairperson, Dr. Renu Chag. She is the president, Bhiwani Obs and Gynae Society. She is also consultant and IVF specialist at Chag Multi-Speciality Hospital, Bhiwani. And she's in private practice at Bhiwani from the last 35 years. To her credit, there are many awards and achievements. Is President Foxy Branch Bhiwani, President Haryana Isar, recipient of Rashtriya Gaurav Award, and recipient of Golden Aim Award. Has the honor of giving first test tube baby to Bhiwani in 2011. So congratulations for that. And I welcome both the chairpersons, and over to you to conduct this session. And may I request Dr. Amita to invite and introduce Dr. Shivani.
Thank you. Thank you, Dr. Niba. In this session, we have a great speaker, an IVF specialist of Delhi, Dr. Shivani Sachdeva Gaur, and she's going to talk about PCOS and infertility. As everybody knows that PCOS is very common in our scenario, and infertility is one of the most important syndrome of this condition. And to deliver this lecture, Dr. Shivani, that I told you, as she's IVF specialist, a great leader, because I can see her CV that she is founder secretary of Delhi State Chapter of ISAR, secretary Delhi State Chapter of ISPAT, secretary general INSTAR, that is Indian Society for Third Party Assisted Reproduction, and she is also ex-vice president of Delhi Gynae Forum South Delhi, vice chairperson of Women Doctors Wing IMS South Delhi. So very good leadership quality you have, Dr. Shivani, and she has more than 10 publications and recipient of Rashtriya Gaurav Samman 2015 and Rashtriya Ratan Samman from Minister of Women and Child Welfare, Government of New Delhi. She is also member of editorial board of International Journal of Reproduction, Contraception, Obstetrics and Gynecology, IJRCOG. And with her huge efforts in 2014, there was surrogacy public awareness walk. It was done in Delhi, and this walk was under her guidance, Dr. Shivani, and this walk was recorded in Limca books. And it was jointly organized by IVF specialist Dr. Shivani and Indian Society for Third Party Assisted Reproduction. It was a great thing, and I think Dr. Shivani is again planning for this surrogacy walk this year. So great to see your CV, and now I welcome you, Dr. Shivani, and invite you to speak on your topic, PCOS and infertility. We are eager to hear you on this very important topic. Now floor is yours, Dr. Shivani.
Yeah,
Amita,
to add to
yeah.
Hi Shivani, to add to
Hi.
her biodata, I must add one thing that in this era of this sudden bringing in the ART and the surrogacy law, she is the person who stood by the side of the doctors and she has gathered all the members from all societies and took to ministry, and every movement she has done in favor of doctors, and we got 6 months period from the ministry. Thank you, Shivani, for
Good.
that great work.
Good.
Thank you.
My God.
Good. I was not aware of this fact.
Yeah, no, I'm falling short of words. Thank you so much, Amita Sinha ma'am and Dr. Ajay Mane sir. Of course, it is effort by everyone. I mean, I'm just a small part of the team. And, all the best for your election. 110%, 200% support. And Dr. Supriya, all the best to you. And POGS, so I really admire like anything. It is so close to me. Patna Obstetric Society, Dr. Vinita Singh and Dr. Renu Chugh ma'am, Dr. Nibha Mohan. Thank you all so much. So opportunity I have today is to speak on PCOS and infertility. Now, in the last 2 years, I'm sure we have all felt like, our lives have been completely shaken up. But sometimes our lives do have to be shaken up, changed, rearranged to locate us to the place where we were meant to be. And in terms of PCOS and endocrine disorder, it affects more than 7 million women. That's more than the number of people diagnosed with breast cancer, rheumatoid arthritis, multiple sclerosis, and lupus combined. Indeed, it is the most common endocrine disorder in reproductive age women with prevalence from 5 to 15%. And infertility problem in PCOS is the number 3. So the major problem that people come in PCOS with is hyperandrogenism, body hair. The second you will be really surprised to see is emotional problems. That ranks second, followed by infertility and then menstrual concerns and weight concerns. So this diagnosis is known by heart to all of us, but just to complete the subject, Rotterdam diagnostic criteria is otherwise includes a combination of clinical and biochemical evidence of hyperandrogenism,
Slides are not moving.
Not
It's not moving.
Yeah.
Oh, can you see it now?
Yeah.
You can make it full screen.
I was doing the full screen, but it was not moving. Now, can you see it?
Yes, it's seen.
Okay. So this is the Rotterdam criteria slide.
No, it is.
No,
Yeah,
ma'am,
yeah.
it is that.
Because I don't know which slide is being seen. Oh.
There's a infertility and PCOS, the first one, I think.
Yeah, no, the first ones, I think they are all gone. Let me keep it like that only because I don't understand what is going on.
Okay.
But if this
Chitrakala, can you help?
Sure, sir. Ma'am, you want to share again, ma'am? Please stop share, ma'am.
Okay, stop share.
Now please share again, ma'am. While sharing, please don't select any of the dialog box, ma'am. Green color share screen and then blue color share. That's it, ma'am.
Share. I'm sharing this presentation. Now, can you see the infertility problem ranked third highest is written?
Yes, ma'am, but not in the slideshow mode, ma'am.
Okay, now this is slideshow. So is it seen?
No, ma'am. No, ma'am.
I think there is some problem with the slide, or I don't know.
No, ma'am. You should not select any of the icons in the dialog box, ma'am. Please stop share, ma'am.
Yeah.
Please click the share screen and
Yeah,
then
done.
color share. That's it, ma'am. Don't click on any of the icon, ma'am.
Okay. Okay. Got it. Now is
Yes,
it
ma'am.
fine?
Yes, ma'am.
Okay.
Perfect.
Thank you. Thank you so much. I was making a mistake. Thank you.
No problem, ma'am.
So this is the Rotterdam criteria, and this is the phenotype 1 or the classic PCOS. Then we have the NIH criteria, National Institute of Health, which is phenotype 2, where PCOS on ultrasound is not required. Then we have phenotype 3, which is ovulatory PCOS. So obviously you will not have oligo or anovulation. and the phenotype 4, which is non-hyperandrogenic PCOS. So there is not going to be any evidence of hyperandrogenism. And I always remember that the adolescent diagnostic criteria are completely different because PCO morphology is perfectly normal in adolescents, and it is only the evidence of hyperandrogenism with abnormal bleeding pattern which helps to diagnose PCOS. So the fundamental defect in most cases of PCOS is a functional ovarian hyperactivity which seems to disturb intra-ovarian processes which normally coordinate ovarian and androgen secretion. In the typical or the functional PCOS, what we would find is that 17-alpha hydroxyprogesterone hyperresponse to HCG or GnRH agonist test, whereas in the atypical, there will be lack of this hyperresponse. So PCOS is a multi-system disorder, a metabolic syndrome underpinned by insulin resistance and obesity. But somewhere paradoxically, the ovarian sensitivity to insulin is increased. So it's the peripheral tissue sensitivity to insulin which is reduced, and there is resistance. These are the diagnostic criteria, but I want to focus on this one. So it is day 2 or day 3 cycle scan where there is transvaginal ultrasound, 12 or more follicles 2 to 9 millimeters or increased ovarian volume more than 10 millimeters. Androgen excess society criteria is that the threshold count should be more than 25 antral follicles, not just 12 antral follicles. And even if it is present in one ovary, and follicular distribution and stromal volume echogenicity can be omitted from this. So generally, if a woman of PCOS comes to your clinic for infertility, what tests will you do for her? The first thing you should think of is day 2 or day 3 serum FSH, estradiol, thyroid function and prolactin blood test, a free testosterone and a free androgen index. You may do DHE sulfate, or you may just stick to one test, which is the anti-Mullerian hormone, where the threshold now it is being said is more than 5 nanogram. What about the LH-FSH ratio? Women who have functional hypothalamic amenorrhea may have elevated LH to FSH ratio, and they are variable because these hormones are released in a pulsatile manner, so multiple measurements are needed. So levels may also be blunted by increasing obesity. So the traditionally held belief of this LH-FSH ratio, you have to remember all these 3 points, that it may not be so reliable. And also the point to make here was that hyperinsulinemia can be seen even in 50% of non-obese PCOS. So don't just think hyperinsulinemia in obese PCOS. In fact, an insulin level should not be diagnostic of PCOS because there is no validated assay for insulin and their levels are very variable. So will you use AMH or will you use AFC? Both are comparable predictors of quality and quantity of ovarian responsiveness. AMH flexibility is there that it can be done at any time in the cycle. And in fact, the task force report from the Androgen Excess and PCOS Society, so this is one of the major publications for PCOS, and what they have mentioned is that the threshold for 12 follicles should now be changed to 25 follicles, and it is something called as FNPO, which is a follicle number per ovary. It is recommended over ovarian volume because FNPO has a greater predictive power for PCOS and less variability amongst population age 18 to 35 years. Especially now we have newer imaging technologies where we have our 4D probes, where I use that machine. So the machine, it just sweeps the ovary and counts the number of follicles and tells you the size of the follicle and, gives you the diagnosis. Artificial intelligence, as we all know, is going to come first in radiology. So real-time methods should follow recently proposed standardization. Now, coming to this was the diagnostic aspects. Now, coming towards the treatment aspect. So, the most important aspect, of course, is lifestyle. So, lifestyle presentation I will do at the end because I have a complete, something about our diet chart and all how we do. Coming to the ovarian stimulation in women with PCOS. So the main symptoms of infertility are anovulation and oligoovulation. And the main methods we use for stimulation are clomiphene citrate, letrozole, some other SERMs like tamoxifen, low dose FSH, gonadotropins with agonist or gonadotropins with GnRH antagonist. What are the challenges that we face? Disturbed follicular genesis, premature luteinization, higher risk of ovarian hyperstimulation, resistant to stimulation, multiple pregnancy, and a high miscarriage rate. So this is something called as the ladder of PCOS. And in fact, in my clinic, I show this to most of the patients who come for treatment who have PCOS. It's a very simple but a beautiful diagram. 1 to 4% is the success rate according to them for expectant management. IUI with clomiphene citrate success rate is somewhere between 6 to 9%. Gonadotropin and IUI 9 to 14%. And IVF they quote as 70%. As the complexity of the treatment increases, the cost of the treatment increases, the stress increases, and the pregnancy rate also increases. So what we have is oral autologens and injectables. Now, clomiphene citrate is a SERM, usually started between day 2 and day 5 at the dose of 50 to 100 milligram per day for 5 days. Over response, you can reduce the dose to 25 milligram, and if no ovulation, increase by 50 milligram increment, maximum of 150 to 250 per day, with dose being adjusted according to the BMI. It is structurally similar to estrogen and blocks the estrogen hypothalamic receptors, which triggers the release of FSH from the anterior pituitary. In clomiphene resistant, which means failure to ovulate with clomiphene citrate 150 milligram for 5 days for 3 cycles, that is the definition of CC resistance. And CC failure is failure to conceive in spite of ovulation with CC for 6 cycles. Now, so what do we do in these cases? There are some studies which suggest that you can go for letrozole or gonadotropin. Let's come to letrozole first. The new recommendations which have come in many societies, this is the study that I have published, that I have presented from First-Ter 2018. Letrozole should be the first line pharmacological therapy to improve fertility outcome in women with PCOS and anovulatory infertility with no other infertility factors. It has a higher pregnancy rate and increased live birth rate compared to CC, significantly short time to pregnancy as compared to clomiphene, 4 versus 6 treatment cycles. And this is from Cochrane, Franek et al. 2018, aromatase inhibitors in PCOS. Now, in 2018, also these international evidence-based guidelines came out for the management of PCOS. And they also reiterated that the first line management treatment, that is the non-pharmacological, is lifestyle and pharmacological is letrozole. So as of now, all the evidence points to letrozole being the first choice in treatment for infertility. Next comes clomiphene, then clomiphene citrate plus metformin, then only metformin. And the second line pharmacological agents are gonadotropins or laparoscopic ovarian surgery, and of course the third line is IVF. Letrozole has higher live birth rate as compared to clomiphene. Possibly it could be there increase in intrafollicular androgen concentration, increase in the ovarian follicular FSH receptor, improved oocyte quality, and lower mid luteal serum estradiol level due to and higher progesterone levels. So oral route, cost effective, minimal side effect, risk of OHSS is much less, multiple pregnancy is much less. So all these make letrozole to be the first choice in treatment for PCOS. and there were some safety concerns, as we all know that letrozole was withdrawn, but this possible teratogenic effect in early follicular phase theory has been completely rejected now, and it is supposed to be absolutely safe. Now, metformin or gonadotrophins, where will you go in CC resistance? So gonadotrophins, where available and affordable, should be used in preference to clomiphene citrate combined with metformin, because in women with PCOS, the pregnancy rates are found to be much higher with gonadotrophins. Clomiphene citrate can be combined with metformin rather than giving it alone in women with PCOS who are CC resistant to improve ovulation rate and pregnancy. So although metformin can be combined, but gonadotrophin is superior. What about letrozole versus gonadotrophin for CC resistance? So patients who fail to conceive with CC, they have a higher pregnancy rate for ovulation with gonadotrophins as compared to letrozole. For the purpose of counseling, 3 to 10% pregnancy rate with letrozole versus 10 to 20% with gonadotrophins. Pregnancy rate with letrozole itself is high enough that we can justify its use to CC resistance, but not more than 3 cycles. Now, what about the role of gonadotrophin versus ovarian drilling? 8 trials, 1,034 clomiphene resistant patients compared live birth rate in women undergoing laparoscopic ovarian drilling to those undergoing medical treatment by Cochrane Library, published in 2012. So there is no evidence of significant difference in pregnancy, live birth or miscarriage with CC resistant undergoing laparoscopic ovarian drilling as compared to medical treatment. But multiple pregnancy rates in laparoscopic ovarian drilling are low, so it makes this option attractive. Now, gonadotrophins. Which gonadotrophins will you use? In women who have PCOS and CC resistance or failure, we found there is no evidence of a difference in live birth rate between urinary or recombinant FSH, HMG, or highly purified HMG. Evidence of all outcomes is very low quality, so we suggest weighing the cost and convenience in the decision to use one or other. This is called as a complete circle. So we started with HMG, gonadotrophin, then we shifted to FSH, now back to HMG. That HMG is equally effective. And how do you use it? It is your choice. You can go for a low dose step-up protocol, which is the preferred method, where we have a slow gradual increase in doses until a dominant follicle emerges. The first increase in dose in this is after 14 days, daily 75 IU, and you can increase by 37.5 IU per day weekly. Chronic low-dose step-up protocol gives you mono-ovulatory cycle, 70% pregnancy rate of 20% per cycle, 40% per woman. OHS's incidence is very low, safe and effective protocol. This is in a pictorially description of the same thing. So starting dose between 37.5 to 75 IU, a scan on day 7. You can increase the dose by the same amount weekly till you reach the trigger size where the follicle is 17 and above millimeters. Then we have a step down protocol where the treatment is started with a higher dose of 150 to 250 FSH for 5 days, ultrasound every 2 to 3 days. Here you cannot wait for a week because the dose is high. So as soon as your follicle is more than 9 millimeters, reduce by 37.5 units every 3 days and maintain it at 75 IU. If the follicle is still less than 9, increase it by 37.5 international units. Now there is a combined protocol where you have step up and step down. So increase step up till the lead follicle becomes 14 and then step down. So why to step down? This is because it's really fantastic. When you step down, all the small follicles, which can then grow and give you OHSS or multiple pregnancy, they undergo atresia. So this combination of step up and step down really works very well. Now, what about the trigger? When to give the trigger and with what? For oral ovulogens, follicle size more than 18. For gonadotrophin, 16 to 18 is fine. And generally, we are preferring a GnRH agonist trigger. Pause and think. especially for IUI or timed intercourse, if there are more than 2 follicles of 16 millimeters, more than 8 of 12, and serum estradiol more than 1500 picogram, because there is risk of hyperstimulation and multiple pregnancy. So this was the committee opinion from ASRN that cycle cancellation if more than 2 follicle, more than 16 millimeter develop, or 3 intermediate size follicle, luteal phase support is beneficial in women with PCOS. So in case you have a troubling situation, what are your options? Withhold HCG, wait for spontaneous rupture, use GnRH analog as trigger, or convert it into an IVF cycle with the help of GnRH antagonist. So what about these antagonist protocols? There is their role. So many pharmas come and tell you it will reduce the risk of OHSS, prevent premature luteinization. So this was the study which was published, meta-analysis of GnRH antagonist protocol. Do they reduce the risk of OHSS? And really what was found was that GnRH protocols of antagonists do lower risk of OHSS. You have lower gonadotrophin dose with comparable clinical pregnancy and ongoing pregnancy rates. So antagonists can help you with reduction in OHSS. Now, the role of letrozole is also there in women with, so letrozole also has a role in women with IVF and ICSI. So there are some cases where we do superovulation by using letrozole. And this was a study which compared PCO, where there was ovulatory cycle, no hirsutism, PCOS with normal physiology. And what was found was patients with PCOS are at similar risk of developing severe OHSS as compared to women with normal ovaries, and pregnancy outcomes are similar in all the 3 groups. Now there is a concept of segmented IVF in PCOS. This is perhaps one of the most important concepts in PCOS, because this is something we are following day in and day out. Remember, there are 3 maternal deaths per 1 lakh stimulated women. And this can be completely erased if we use antagonist protocol, agonist trigger, freeze all the oocytes and embryo transfer later. And this very simple concept is what is called a segmented IVF, described by Paul Devroy. And see, in the world today, what is happening is the CDC has described dramatic rise in frozen embryo transfer cycles. ESHRE data has also said there is a strong increase in freeze-all cycles, that pregnancy and live birth rates are in fact higher after frozen transfers than after fresh cycles. So the new era in ART, especially for PCOS, is segmented IVF, and it is a more optimum strategy, not only in terms of reproduction, but fetal and maternal outcomes. So women who have oligomenorrhea and infertility, first thing, exclude all other etiologies, look for diabetes, hyperlipidemia, hypothyroidism, optimize their lifestyle, do routine prenatal counseling, vaccination. Then if there are, for obese women with PCOS, advise weight loss, diet and exercise, especially if BMI is more than 27. Do a routine infertility evaluation, correct abnormalities, check for tubal patency, male factor, endometrial cavity, initiate ovulation induction. You can go for letrozole or clomiphene citrate for 6 cycles. If high risk for OHSS, go for, maybe you can turn it into an IVF cycle. If there is resistance, go for laparoscopic ovarian surgery or exogenous gonadotropins with and without IUI. Just a word about laparoscopic ovarian drilling. The mechanism is unclear, but may be related to destruction of androgen production tissue. And one commonly used regimen makes use of the monopolar cautery for 4 punctures, 7 to 8 millimeters at 30 watts power, 4 to 5 seconds, and live birth rate is comparable to gonadotropins. At the end of the talk, just to summarize, the most important factor in PCOS, the lifestyle factor, the diet factor, diet and nutrition. It is what is the low glycemic index is really the crux of the diet that we should be prescribing. And different diets which have been suggested include low GI diet, high protein diet, keto diet, DASH diet, Mediterranean diet. So there are so many diets which have been recommended. There is no single diet which is superior to other, just low glycemic index. That is the catchphrase. Small to moderate amount of weight loss, just 5 to 10%, negative energy balance, 350 to 1000 calories. And with this, the menstrual cycle is improved, ovulation, lipid profile, insulin sensitivity, and quality of life. The adoption of DASH or Mediterranean diet should be encouraged. Diet rich in fiber with 30 minutes of moderate intensity exercise per day. Avoid eating very late. Have a light dinner. Major consumption in the daytime. And this is like generally I give this to my patients, a sample North Indian diet. This is what you should take at what time, and this is something that they really find helpful. And I tell them, let thy food be thy medicine, and thy medicine be thy food. So victorious warriors win first and then go to war, while defeated warriors go to war first and then seek to win. So I'm sure all our election candidates, Dr. Ajay Mane, Dr. Supriya, you are all victorious warriors. Thank you everybody for a very patient hearing.
Thank you.
Thank you, Shivani, for the blessings. Thank you very much for accepting our invitation and coming in spite of your busy schedule. Thank you very much.
Dr. Renu. Unmute yourself. Dr. Renu, unmute yourself.
Okay, hello. Am I audible now?
Yes, yes.
Dr. Shivani, thanks a lot for your wonderful presentation as usual. You always do such a clear and give so clear concepts to the delegates that doesn't leave anything to be discussed later on. Especially your protocols were so good. Yes. I mean, letrozole in non-IVF and segmented IVF. That is the best thing to remember in PCO patient, I would say. And that, of course, is the keyhole treatment. So can I ask you one question in diet? What do you think, Dr. Shivani? Banana, you think is a low glycemic diet or it affects PCOS in a negative way? What is your opinion?
Actually, I tell patients to avoid banana. So there are 5 fruits which are to be avoided, and that is guava, chiku, mango, banana, and grapes. These foods have a very relatively higher sugar content, and we follow like the diabetes plan. Even the diabetes patients avoid these fruits. But I'm sure that anything in moderation is okay. If they have a craving, they can always take it. But it's not one of the fruit that I would recommend.
No, but recently, even I was of the same opinion. I never used to tell my patients to take banana. So why I'm asking you is that recently I have read about banana and it says that it has a low glycemic index. And bananas, they are high in potassium and low in sugar, they say. And it doesn't increase your glucose uptake. So they say it is the best food for PCOS.
That's great, ma'am. Thank you.
Maybe you can search on web and read. This is the latest opinion. Yeah.
Thank you. No, of course, every day new studies are coming out. So it is so good to know that. In fact, in OPD a few days ago, one patient came to me with a big packet of PCOD tea. So there are these marketing companies now, they have come up with PCOS tea and PCOS snacks.
I know. These are all, I think they are marketing strategies. So thank you very much for your excellent presentation. And I thank Patna Society for inviting me. And of course, my best wishes for Dr. Ajay Mane, Dr. Kirmani, Dr. Supriya, everyone for their elections. And of course, my society support is with you. Okay.
Thank you.
Thank you very much.
Madam. Thank you very much.
Dr. Shivani,
can I add one thing that in recent studies they have shown that 25 grams of fiber must be taken by male and 20 grams fiber must be taken by female for the good ovum and sperm qualities. Likewise, the research is going on daily basis. So few suggestions are accepted on daily basis. The fiber. Basically, what I see is our old traditional Indian meal is proved to be best in nowadays.
Yes, it is absolutely the craze now over here. Bhakri, jawari, roti, and everything. It has become
gluten-free diet.
so
We
much
should not take
craze.
wheat.
All
Wheat
the
should not be
organic
taken.
shops have this millet.
Yes,
We
and they
should have
always
a
said
gluten-free
avoid maida, avoid
Even
excess
wheat
sugar,
also they
avoid
say
excess
avoid.
salt. That's all.
Thank you, Dr. Shivani, for your wonderful talk. And on behalf of Dr. Renu and myself, I thank the organizer for giving us this opportunity. And now I request Dr. Supriya Jaiswal, POX Secretary, POX, to propose vote of thanks. Supriya, please.
Yeah, thank you, Amita-di. So at the outset, I would like to thank the audience, everyone, the esteemed chairpersons, starting from the chief guest, Dr. Alka Kriplani, madam, who really agreed to come in spite of that she's very busy. Then Dr. Alka Pandey, ma'am, and Dr. Achala Batra for being the guest of honor. And the wonderful speakers, Dr. Vinayak, Dr. Ajay Mane sir, Dr. Shivani. I couldn't get in touch with you today because, but still you came up. I thought there must be some issues, but thank you very much and coming and updating us. Then all the chairpersons, Dr. Vinita Singh, Dr. Own President, Dr. Vinita Singh, Dr. Kiran Mai ma'am, Dr. Vandana Punya, Dr. Sapna Zindal, Dr. Meena Samant, Dr. Monica Gupta, she was logged in right from the start, Dr. Amita Sinha and Dr. Renu Chug. Madam, I really thank you, all of you, the dear viewers, and our convener of today, Dr. Nibha Mohan, Dr. Amita Sinha, and everyone who was present here. Thank you very much. And Dr. Ajay Mane sir, Dr. Kiran Mai ma'am, thank you. And all the best. All the best.
Ajay sir, all the best. All the best.
Bye-bye.
Best.
Thank you.
Thank you very much. And Kiran Mai, best luck. Supriya ji, best luck.
You too, sir.
Dr. Kiran, my best of luck. I'm so sorry I missed out your name.
शिवानी जी, हम सब लोगों को आपका सपोर्ट बहुत ज्यादा जरूरत है, आपकी सपोर्ट की. You and your association and all your members and friends kindly help us. Thank you.
Definitely, Ajay sir. We have an installation of the ISAR president now on 4th in Delhi.
4th, yeah.
So there will be people will be coming, and I will definitely campaign for. I think Dr. Supriya is more for president and secretary, but for you also and for all three of you, sure.
Thank you very much. Thank you very much.
Thank you so much.
And thank you, Patna OBJ Society, for giving me chance. Thank you very much.
Yeah,
thank you, sir.
Thank you, Amita ji.
And
thank you, Sapna ji. Virendra Singh, madam.
Sir, we thank the Shield Connect, Chitrakala ji and Dr. Stalin.
And Dr. Stalin. Yes.
Thank you, sir. Thank you very much.
Thank you so much, sir.
Thank you very much.
Thank you very much.
Bye. Good night.